I'd like to start kicking off the afternoon session, or to the third day of Research Week. Just want to welcome you all to this session. I'm Nadia Wise, I'm a vascular surgeon. I'm also acting in clinical governance roles and also currently acting as Clinical Director of Surgery, and it's my absolute pleasure to be chairing this session today. First of all, I'd just like to acknowledge the Kaurna people as the traditional owners of the lands that we're on. It's the Adelaide Plains, and we respect their spiritual connection to country and respect their leaders past, present and emerging. To begin the session, as always, there's online questions. So if you'd like to scan the QR code, it will take you to the questions. Otherwise, you can just go to the website, slido.com, and type in the code. So that means that after Erin's talk, we'll have the questions pop up on screen and it will help facilitate the Q&A. And it is absolutely my great pleasure to introduce Associate Professor Erin Simons. She's our Senior Research Science for Bowel Health Service here at SALHN. I'm going to go to my notes because I met Erin 5 minutes ago, and so we were just catching up. Erin is actually, she's the lead of the Bowel Health Sciences Service Research Team here at SALHN at the Flinders Innovation for Cancer. Her team's research focus is on cancer biomarkers and prevention, and through NHMRC funding, which is absolutely spectacular, and the Medical Research Fund and the Hospital Research Foundation, the team are now developing and optimising non-invasive diagnostic screening and surveillance techniques for gastrointestinal cancers. Today's talk is about that, but also about how, as the title of the session is, from little things, big things grow. And this is how we show how quality improvement processes, which is dear to the heart of all the surgeons at SALHN because it's come from our division, but how quality improvement can inform the National Bowel Cancer Screening Program. So welcome, Erin, and thank you.
Thank you very much. I'm really excited to be sharing with you some of the work that's been done over the years, a project that started off as a little project in Flinders Medical Centre and has now grown to a much bigger project. And I'd just like to add my acknowledgement to country, to the Kaurna people, the lands we stand on today, and honours their elders past, present and emerging. Now, for this talk today, I'm going to take you on a bit of a journey. So this might be a bit of a journey through the gastrointestinal tract, looking at from little things, so little polyps. These can grow into big things. So these can grow into cancers. So we'll be doing a journey through the gut and the gut health. We'll also be taking a journey from little things such as little ideas, little bits of money, and a little hospital in South Australia, and how over a 24-year period, these ideas have launched from little ideas to big ideas. It's received MRFF funding and it's expanded from just Flinders Medical Centre to 8 different hospitals across South Australia. So it's really exciting to be able to share this information with you today. So the journey will go on. We'll discuss a little bit about the past, the present, and where we are planning to go for the future. So just to set the scene a little bit, back in 1999, so 24 years ago, looks like most of you in the audience are too young, much too young to remember this era. So I'll give you a little bit of a refresher. What we saw back then was VHS videos or beta videos. They were on the way out and being replaced by DVDs. Spice Girls, they were in. But to be honest, their songs from 1999 weren't as good as they were from 1996. The must-have technology was the Apple iMac. This big chunky computer, for those that don't recognise it, that was what everybody should have on their desk. We got told to avoid this new company called PayPal. What it was said in 1999 is it was voted as one of the worst business ideas ever. And we were all very fearful about the Y2K bug because when midnight hit in the year 2000, in 1999, turning 2000, everything was going to crash and it was going to be a disaster. But while all of this was going on in the world, we also had innovation happening at Flinders Medical Centre. And this was done by Professors Graham Young and Peter Bampton with a lot of innovation from Jane Sanford and Joylene Morecambe. And what their goal was at Flinders was to improve colorectal cancer prevention. And we do have some people in the room here that were involved in these very early stages, so it's nice to share their story. So colorectal cancer, this is what they wanted to prevent. So who is actually at risk for colorectal cancer? Well, it's about 1 in 14 of us from the Australian population. But the good news is there's a screening program in place with fecal occult blood tests or fecal immunochemical tests to help find individuals who are at higher risk for bowel cancer and to work out who should have colonoscopy. We have individuals in the community who might be having symptoms, so gastrointestinal symptoms or iron deficiency anemia. These symptoms might suggest there's a higher risk for colorectal cancer. There's also individuals who are considered at a higher risk for colorectal cancer, and this is because they have a significant family history of bowel cancer or they've had previous adenomas. And this can account for around about 5% of the population with a family history, or up to as many as 23% of the population with these adenomas or polyps found. And of course, we have a really important group of individuals who are bowel cancer survivors. So in 2016, 55,000 individuals who were living after having a bowel cancer diagnosis. These individuals have a high risk for the bowel cancer coming back again. So all of these individuals need to be monitored carefully. Now, we have got funding from the NHMRC to look into fecal biomarkers that might help our group with symptoms, and we'll be hearing later today from one of our MD3 students up the back there, Jennifer. She'll be presenting on the results from this. And we are also using MRFF funding to investigate blood tests for keeping an eye on patients after they've had bowel cancer. So the focus today is to talk about individuals who are at increased risk because of their family history or because of having these polyps found before. And what's recommended for these individuals is that they should have regular surveillance colonoscopies. Now, the reason that these colonoscopies can reduce cancer risk is because a colonoscopy, I'm not sure how many people are familiar with them, but it involves basically a camera being placed into the large bowel, up about 1.5 meters, and it gives a chance for visualisation of the bowel to see if any of these polyps are growing. Now, if any of these polyps are a little bit sort of more developed and they're adenoma types, what can happen? If they're left in place for long enough, some of them will become cancer. And so by locating these polyps and removing them, it gives an opportunity to prevent the cancer from developing. So very simple. And if there is a cancer found, by keeping an eye on people, if we catch it early, the good news is 98% of bowel cancers can be treated successfully if found in these early stages. So this sounds really good. So maybe we should be doing as many colonoscopies as possible, guarantee more cancer prevention. That's a great idea, but we do have limited resources in the Australian healthcare system. It is an invasive procedure that requires anaesthesia and there's risks of perforation. Does have cost to the healthcare system and sometimes to the patients. And it also involves bowel preparation, which is the laxative. Now, for those people who may have undergone a colonoscopy, here's an example of what they may have to drink before their procedure. So it could be up to 5 litres, normally about 3 litres, of liquid laxative to clean out everything to make sure they have a good procedure. And we hear from the patients who call up that that is the worst thing of the whole procedure. So these people, once they're identified as being a higher risk for developing colorectal cancer, they do have these regular surveillance colonoscopies. And this generally goes until about age 75 or until an individual is considered at no longer elevated risk. And these happen around 1, 3 or 5 years. Now, to take us back to where this all began, what was done was an audit by the team back in 1999 at Flinders. And what was observed is there are large numbers of colonoscopies happening and clinic appointments as well. So obviously, try and reduce the risk for cancer. Or there could be other reasons as well, why the doctors were recommending so many colonoscopies. But what they found is that only 37% of the colonoscopies were being done at appropriate intervals, because there's national guidelines in place saying how often these should be done. And what was being seen is that colorectal cancer was still being found despite these regular colonoscopies. And this wasn't just an issue at Flinders Medical Centre, it was happening across the world. So the way that most patients come into regular surveillance colonoscopies is that they're identified as being at higher risk, They need to visit their GP and get a referral for their gastroenterologist. They'll have a clinic appointment. They'll have the bowel preparation and a colonoscopy, another clinic appointment with the gastroenterologist who will then recommend when the next colonoscopy should be. Now, this gives an example. It's an actual screenshot of what the national guidelines are, and very complicated. It doesn't just depend on what is found at each colonoscopy, but also the colonoscopy prior to that and what the family history of a patient may be. So it's not surprising that recommendations might, they're very complex, so recommendations are not always correct. But when we consider approximately 300,000 surveillance colonoscopies are being done each year in Australia, we need to get this right, because otherwise there's a risk for patients being lost to having ongoing surveillance, or there's a risk for different recommendations being given. And an audit that I saw at a conference recently even showed that up to 89% of colonoscopy timings in their own institute, I think it was in New South Wales, did not match recommended guidelines. So this is a common theme that we're seeing in all hospitals. The consequences are, as I've mentioned, if it's too frequent for colonoscopy, there's a risk of complications from the procedure for the patient. There is additional burden for the patients undergoing all of these bowel preparations, taking time off for their procedure, additional burden to an overloaded system, and extra cost, of course, to the healthcare system. If the procedures aren't frequent enough, there's the risk that some of these adenomas, if they're not found, they can go on to develop cancer. And if a patient's not recalled at the right timing, they may be lost to follow-up. So the colonoscopy frequency should follow evidence-based guidelines to minimise the risk of cancer in the population. So what was decided back in 1999 is that the system was not working. A new method was needed to improve compliance with national guidelines. So the question was asked, how do we get the doctors to follow these guidelines? And the answer was, well, we'll replace them with a nurse, of course. So the role of these specialised nurses was to review the colonoscopy results and to suggest that they're trained in what the guidelines are. They suggest what the next recall interval should be. They remove this need for the clinic appointments with the gastroenterologist or with the surgeons, and they ensure that all patients are maintained in the program. And this commenced in 1999 as a quality improvement project in Flinders Medical Centre. And this was named the SCOOP program. And the way that it transformed the healthcare is that individuals coming in for the colonoscopy, all colonoscopies were reviewed. If the patient was considered higher risk, they were enrolled into the SCOOP program. Nurses made the recommendation of what the next surveillance interval should be. It was approved by the specialist, and a letter was sent to the patient. And when they're due for their next surveillance colonoscopy, the nurse does a phone interview with the patient. So it's a much simpler process. And you can see we're cutting out a lot of these GP visits. We're cutting out a lot of these gastroenterology visits. So it then leads to significant cost savings through less resources being used, and also reduced cancer risk by making sure the patients get their care when they should be. And in 1999, a 3-month trial, just 3 months, showed that the compliance to recommendations by these doctors increased from 37% up to 96%. So this was an amazing achievement just from 3 months. So let's bring it up to current times. What came next? So looking back to our history chart here, we had our VHS videos. They've now been replaced by Netflix. Spice Girls, well, they're still in. I don't know if they should be. Must-have instead of the Apple iMac is, of course, the Apple Watch. PayPal has 435 million users, so no one listened to that advice that it was a bad idea. And the scary thing that we encounter now with technology is when we get an unknown phone number calling us on our mobile phones. But innovation was still continuing since 1999 to really reduce the risk of bowel cancer. And so what came next for the SCOOP program was that it spread from Flinders Medical Centre to the other SALHN hospitals. So started off in the Repat Hospital, then in 2017 moved to Noarlunga Hospital. And it was also trialled in a few of the private hospitals. Now, with the private hospitals, they decided to go for a slightly different method, and they didn't use a nurse-led process. Instead, they developed paperwork that the doctors could read what the recommendations should be. They'll tick a box, And that, it's a bit of a better care model, but it's still the doctor making that decision based on a paper-based guide. So we were able to, a few years ago, compare how the systems were going. And we published this in the Medical Journal of Australia. And in 2015, what we saw that the Scoop colonoscopy program in Flinders Medical Centre and the REPAT, after, 16 years, the compliance was still extremely high, 97% matched guidelines. What do we reckon happened in the doctor-led process, though? Maybe not so good? In the private setting, the aid, it was not too bad. It ranged between 32% to 93%, keeping in mind a lot of these doctors in the private system also worked in the public system, so they were aware of the importance of following guidelines, but still we saw the recommendations made by the nurses provided the best compliance with national guidelines. So it's really good to see how well the program was going, and it had longevity in it as well. So we now have a good system set up where the patients are enrolled in the Scoop program, they're provided with the appropriate surveillance colonoscopy repeats. Each colonoscopy is reviewed by the trained nurses and generally goes until about age 75. But what we do is we also take all of this information that's gathered within SALHN, put it within our colonoscopy recall database so that we can do research with it as well. And to share you some of these outcomes from our research program, we have seen over the years that we have been reducing cancer risk, and this program has had good consumer acceptance. So the first thing that we've observed is over the years, what we need to ensure that with a colonoscopy, it's really good quality. If it's a poor quality colonoscopy, there's a chance that something could be missed. And so over the years, since 1999, we're still, there's still occasions where the colonoscopy might not be perfect, but we can see we've got a really good decline in the number of the poor procedures. So this has more than halved in the number of poor procedures, so a really good outcome there. And work from one of our MD4 students, Angelo, he has also looked at what's happened to the cancer rates in the patients having colonoscopy, and we also see a really good decline here, possibly linked to the improvement with the quality, but also maintaining patients in a good system of care. What he did find is in these earlier time periods that a lot of the cancers that were found were due to polyps being missed at the previous procedures because the quality wasn't so good. And he also found that if procedures are late, that's also when we can see cancers developing. So it also highlights the importance of keeping good, timely procedures happening. So while Angelo found cancer incidence was decreasing, we also saw that the adenoma incidence was increasing. Now, this is a good thing to see because it means that we're catching the lesions at the adenoma stage and preventing the cancers from developing. Any cancers that were found during the program were also detected at very early stages. But it's not just about cancer or adenoma rates, it's also about what the people think when they're undergoing these sorts of programs. So we surveyed Scoop participants, 406 of them, and we asked them what their thoughts were about bowel cancer. And they were still afraid. So they're undergoing this program. They, almost 3/4 were, could tell us that they knew they were at risk for bowel cancer. And almost 60% said that they were afraid that they would get bowel cancer. But when we asked them how they felt about being maintained in the Scoop program, the majority, so 98%, indicated it provided them with this reassurance to be maintained. 96% said it provided them with the appropriate healthcare recommendations of how often they should be having their colonoscopies. And it gave a chance for things to be found early. So the research that's led to this long-term success of the Flinders colorectal cancer program, it's also been highlighted internationally as a model to follow. And that's something that Flinders should be really proud about. The research that we've gathered from collecting all of this data over the 24-year period has also allowed us to do, quality improvement projects to see what the best timing for colonoscopy should be. So here's an example of a paper we published on the sessile serrated polyps a few years ago. And these papers also help to inform international guidelines. So the British Society of Gastroenterology, as well as the Korean Society, they've referenced this paper to help decide how often colonoscopy should be done after these types of polyps. So that's a pretty good outcome as well. But the program does have some challenges in our current year. So the first challenge is there seems to be a lot of people out there at risk for bowel cancer, and a lot of people having colonoscopies. We are seeing an increase every year. There's more colonoscopies being done, and these are just the numbers in SALHN. And that's more than doubled over the 20 years of how many procedures are done for any indication. We look at the indications for people who are considered at high risk for bowel cancer, and we see more and more people each year are needing to be enrolled in the SCOOP program. So once they're enrolled in, they need to keep having their regular colonoscopies, which is adding to the current yearly intake of colonoscopies. So we did some modelling with help from team member Jerry, and we saw that over the next 6 years or so, there's going to be about a modelled, we estimate about 2.8-fold more surveillance colonoscopies that are needed than today. So it's a growing number, but we need to ensure that we can still manage these patients and ensure appropriate care. The other issue with the SCOOP program is it only covers the southern catchment area hospitals. So you can see from this heat map is only the people down the bottom half of Adelaide are being looked after. And we've done an audit of the other main hospitals, and no other hospital is providing this same coordinated care nurse-led model. That's a real shame, because reduced quality of care could be through the colonoscopies not often enough or the colonoscopies being too frequent. So our next goal was to provide equity of care, not just in the SALHN region, but across South Australia for surveillance colonoscopies. So our solution for this is the SCOPES program. So it's like SCOOP, but bigger. It stands for Surveillance for Colorectal Cancer Prevention. And we've managed to achieve funding from the MRFF grant. And we've also brought in all heads of departments from every gastroenterology department from 5 different LHNs. So we have got SALHN, of course, Flinders and Noarlunga. Carlin, we have got QEH and the Royal Adelaide. Narlan, Modbury and Lama Kewan Hospital, the Riverland Hospital and Port Lincoln. So the aims of the SCOPES program over the next 5 years, and it's only just started, is to firstly build a digital surveillance program. We'll then implement it across these different hospitals, and then we'll assess how it's going for feasibility and whether it's scalable to then take it further than South Australia. So the first thing we need to consider is maintaining records. So if we're going to include 8 different hospitals in this, there's lots of different computer processes involved when people are booked for colonoscopy. So we start off with the GPs using their computer system to make a referral. We have the hubs booking clinic appointments with the gastroenterologist. We have, or with the nurse, we have clinic interviews. We then have more bookings of colonoscopy procedures. That should then generate colonoscopy reports, pathology reports, sometimes radiology reports. Sometimes this is fed into the electronic medical record systems of the hospitals. And what we should be collecting as well is patient-reported measures to make sure everything is matching the patient's expectations. So you can see there's lots of different systems, and each hospital also tends to use a different computer software system. So it's going to be a challenge. And the risk is, with all of these different systems in place, you can imagine if any step goes wrong, the patient might not get their colonoscopy. So if the GP referral happens to go missing in a pile of paperwork somewhere, maybe the colonoscopy won't be happening on time. Or when the pathology report comes back, if it's not reviewed properly, we might miss that there's a cancer and the person could be then late having their surgery. So it's essential we have a really good system to look after all of these different clinical systems. So our solution is to create a computer solution that will maintain all of the patient details who are undergoing these regular colonoscopies, and we don't want to duplicate data entry. We don't want to take this program and type it in ourselves. We just want to feed it into a central dashboard. Our next challenge to address with the SCOPES program is the increasing number of colonoscopies. So as I said, this is more than doubled over the 20 years. And the challenge is that we need to review, the SCOOP nurses review every single patient that's undergone colonoscopy to assess their risk status and determine their need for ongoing surveillance. Now, the risk is, as these numbers of colonoscopies are increasing, we need a high workload for this. We can't just keep employing more and more people to cover this. We need to be a bit cleverer. And we also need to ensure that the recommendations given are correct for every single patient. So our solution is, with our computer software, is to create a rule-based algorithm, do a bit of artificial intelligence, and use this computer solution that can provide appropriate surveillance recommendations based on national guidelines, which will then be reviewed by the nurses and the clinicians to ensure everything's going correctly. So what we envisage is that all of this information will be drawn into a central program. The patient-reported measures, all of the referrals, all of the outcomes. We'll be able to automate letters going out to the patients or emails going out to the patients, as well as giving appropriate surveillance recommendations with the help from computer programs. We hope that this will reduce the data entry burden and error risk. It should reduce the burden on the doctors and reduce the time taken to report back to the patients to send them letters, because sometimes this can take months before the patient actually finds out what their result is. And what we'll be doing is also pulling all this information together to create a South Australian registry of colonoscopies, which we hope can then ultimately link to the National Bowel Cancer Screening Program to bring all of these results together for bowel health. And because I'm a bit of a data nerd, I suppose, this will provide amazing research opportunities. And once the software is established, we'll then be rolling out the SCOPES program every 6 months to one of these new local health networks. Then the next step will be looking at the feasibility. We'll make sure that the consumers, the end users, are okay with how everything's going and the communications they get. We'll do this through surveys integrated into the software. And we'll also make sure the clinical staff are okay with, especially from other hospitals, it'll be quite a new process for them. So we'll make sure that it works well for all of the end users. We'll check what the baseline compliance with the guidelines are and see how that improves over the years, hopefully improves. And we'll also look at the cost effectiveness and the scalability. The next step will be to then hopefully roll out into other states. And we do have interest already from groups in Victoria, Queensland, Western Australia and New South Wales. So that's the SCOPES program and the SCOOP history. I just thought I'd finish off by mentioning a little bit about the future. So how can we improve things even further in the future years? And I believe this is through listening to the people having the procedures. We need to know what suits them. So this is some work done by one of my PhD students, Maddie, and we asked people what they actually thought about the colonoscopies. And so this were people in the SCOOP program, and we sent surveys to them, and then Maddie compared how it might compare between the younger age groups and the older age groups. Because you can imagine if someone is, say, 30 when they start having their surveillance colonoscopies, they might be having surveillance for the next 45 years of their life. We need to make sure that they're happy with how the system is working so that they maintain this colorectal cancer prevention activity. So we had 102 younger adults participating in the survey and 187 older adults. And what the younger adults were saying is that they had higher nausea levels with the colonoscopy. So a third of them felt nausea with the colonoscopy compared to only 15% of the older adults. The younger adults, about 1 in 5, said that the procedure was quite costly for them compared to less of the older adults, only 13%. Over 50%, 52%, said that the procedure was really unpleasant of the young adults. And it was pretty much the same for the older adults as well, 48% not liking it all. But the concerning thing is, in these younger adults, they do have a higher fear of cancer than the older age groups. And this is something we really need to address to make sure that they're okay, with their care, to reassure them that they're being looked after. But maybe, the fact that people are having nausea and there's the cost and there's the unpleasantness of colonoscopy, so maybe we can reduce the number of colonoscopies. And what my team has been looking into is whether we can use these bowel cancer screening tests to determine the need for colonoscopy. Again, I think everybody here is too young to have received one of these bowel cancer screening tests. But the way it works is when you turn 50, you'll be sent a free screening test from the government. And the way it works is if anything is growing in the bowel, so these polyps or a cancer, they're going to lose tiny amounts of blood. By sampling a very small amount, like a sort of a rice grain size amount of faeces, we can assess these samples for microscopic amounts of blood to see if these individuals need a colonoscopy to look further into it. Now, some work from one of our MD4 students, Adelaide, looked into whether the scoop patients would be happy to complete these fecal tests, because they're normally just sent to people in the general population, our lower risk group. The reason these were started is the government, it's actually started back in 2006, and we do have a lot of bowel cancer cases in Australia still. So 299 bowel cancer cases every week, 103 deaths. So in 2006, the bowel cancer screening program commenced, where people are sent the free bowel cancer screening test. By 2019, the program was fully rolled out and was sent to people every 2 years from age 50 up to 74. And it's a free test. But the problem is only 41% of Australians are currently doing this free test. So that's, 59% of them are just going in the bin. People are not taking this opportunity to test for bowel cancer and catch it early. So we figured in the scoop population, maybe these people wouldn't want to do the bowel cancer screening test either, because they're doing colonoscopies. They're probably figuring, I'm already covered by the best procedure out there. So Adelaide looked at the first time they were sent a fecal test from us, so over 12,000 individuals. And then he looked at what happened the second round of screening, where there were over 8,000 individuals that he could analyse, and they were sent the second round a couple of years later. And what Adelaide found, 51% of scoop patients were willing to do the bowel cancer screening test despite having a colonoscopy. And the second test that was offered, second screening round, even higher participation, 62% of people were able to complete the test. And when we looked at sustained participation, and this is an important thing with bowel cancer screening, it's not just a one-off, you keep doing the test. Over these 2 rounds, 86% of people, if they'd done it the first round, were willing to do it the second round. So really nice outcome there. What he found is that individuals who were female and older tended to be the higher participants, and those who were more likely to keep doing the test were the older individuals. So it's obviously, this is a test which is acceptable to this patient population. So maybe we can use it to reduce the number of colonoscopies, and work is done by one of my postdocs, Dr. Malawasi. And what he looked at is over these multiple rounds of screening, if a patient has a negative test, either for 1 round or up to 4 rounds, what is the risk of then having something found at colonoscopy? And so he looked at, after each of these rounds, what was found in the future. Were there any adenomas found or cancers found? And he found about 11% of individuals, so keep in mind these are high risk people anyway, about 11% had advanced lesions found at their next colonoscopy after a single screening round. But as more rounds were completed, and if the patients were negative each time for haemoglobin, that risk reduced to less than half, down to less than 6%. So multiple rounds of negative screening tests with the fecal test were associated with reduced risk for cancer or these advanced adenomas. But maybe we can improve this a little bit further by looking at the actual amounts of blood, the haemoglobin, in the samples. Now, we know that the haemoglobin concentrations increase with severity of disease. And what we find is if there's just a small lesion present, there's only a small amount of blood loss. A bigger lesion or a cancer found, much more haemoglobin present in the stool sample. Now, in screening populations, it's known that up to 98% of individuals will not have anything significant found if they've had a negative test result, at that exact same time. Moller has found that more than 94% won't have anything found after multiple negative rounds of the fecal test. So we were interested in whether the fecal haemoglobin concentrations could also predict the future findings in patients undergoing surveillance colonoscopy. So we had over 6,000 individuals who'd completed the fecal test, and what we saw is if they had absolutely no haemoglobin measurable in the fecal sample, less than 10% had advanced adenomas found at that future colonoscopy. If the test was still negative, but there was a bit more haemoglobin present in the stool sample, you can see the proportion of advanced adenomas increased, and this increased further as the haemoglobin levels increased in that stool sample. So this all makes sense. and reinforces that the advanced adenoma, so the risk for anything nasty, was lowest after no haemoglobin present in the stool samples, and no cancers were found in these individuals either. So what we thought is maybe we could use these fecal tests and the haemoglobin levels present in there to help guide the surveillance colonoscopy frequency. And so some more work by Maddie, my PhD student, asked the patients what they would feel about this. She sent surveys to 800 individuals from the SCOOP program, and they were provided with a hypothetical situation saying, okay, how about we give you a fecal test, and if it's negative, you don't need your colonoscopy. But if it's positive, then you can do colonoscopy. 51% of individuals completed the survey, so 406 responses. And what we saw is 72% didn't want to get rid of colonoscopy. They were very uncomfortable with this idea. And the reason that they were uncomfortable with the idea, it was predicted by their fear of cancer. It was predicted by how much they trusted the results from colonoscopy. And also, if they found colonoscopy easy to do, they wanted to keep doing colonoscopy. So this was an important outcome. We also asked them about other changes to surveillance, gave them a few different scenarios, and instead of reporting the discomfort, this is just graphed as how many were comfortable. And so, as I said, only 13% were comfortable with the idea of only doing fecal tests. So we're like, okay, well, colonoscopy is the gold standard for surveillance. How would you feel if we only gave you colonoscopies? And that was even worse. Only 12% were like, well, that doesn't sound good. So we're like, okay, well, we'll give you a combination. What about colonoscopy every 10 years, so a bit longer than what you're used to, and fecal tests every 2 years? A little bit better. 21% were comfortable with that idea. Then we're like, okay, what if we increase the frequency of the fecal tests? Very similar. So, the 10-year colonoscopy wasn't ideal. So we're like, okay, what about colonoscopy every 5 years and fecal tests every 2 years? Well, we got double the amount of comfort there. What about increasing fecal tests to every year? Almost 2/3 of people like that idea. And then we're like, okay, well, what about whatever the SCOOP clinician, the SCOOP team recommends for your surveillance? Are you comfortable with that? And that's where we saw. They were happy. It really shows good support of the SCOOP program because the consumers are trusting what's recommended to them. And we use the appropriate guidelines to make these recommendations. But we have taken this information, and because we do see discomfort with the idea of not doing colonoscopy, we're going for a bit of a conservative approach. And this is one of our NHMRC grants, which is coordinated by Dr. Jean Winter up the back there, doing an excellent job with this. And what we're doing is we're using the SCOOP patient results, so the fecal test, and if we see there's a very low level of haemoglobin, Jean is then randomising these individuals, inviting them to the study and saying, well, you'll either have your colonoscopy on time or you'll be randomised to having it delayed by 1 to 2 years. And from this study, it's a 5-year study, we'll assess the safety of extending the colonoscopy intervals by using the fecal test results. We will assess the cost effectiveness of such a process, and we'll also see surveys throughout the program to make sure people are comfortable with this approach. And these are just some preliminary results because the study's ongoing on how the enrolment is looking. And Jean is currently seeing a 47% consent rate. And the highest consent is from males. So the odds ratio is 2 times that of females for agreeing to be part of this study. It's not affected by the age of the individual, how often they should be having colonoscopies, or whether they've got private health cover. And Jean's finding when she speaks to these individuals, their main reason for declining enrolment into the study is they don't want to delay their colonoscopy. So this is an example of shared decision-making, really, because we're giving people the option of, do you want, we believe it's safe to delay your colonoscopy, but how do you feel about it? And only half of them feel okay to take that option. Why there's more guys taking up that offer, whether it's because they don't read the information sheet properly, but Jean does a very good job of explaining it to her, or whether they're more likely to take more risks with their health. But we know this is a safe approach, and so it's a really nice study to be doing. So to summarise the findings from our future research, we do see that 50% of individuals do not like colonoscopy. There is nausea, there's the cost issues, but we do see that the fecal tests are effective to screen for cancers. But people within the SCOOP program don't want to replace the colonoscopy with the fecal test, but they are willing to do both. They tell us they're willing to do both the colonoscopy and the fecal test. But when we actually trial this, we find that only 50% are actually willing to do this. And it could be that these people are the same as the people who don't like the colonoscopy. And so we'll be looking further into this. So it sort of leaves us with, well, what do we do next? But what it shows us is that one size does not fit all for healthcare, and personalised surveillance is really needed. And that's what we're driving from this project that started at Flinders Medical Centre. The outcomes from this over 20-year journey, we're coming to the end of the journey now. Well, we're coming to the end of my talk, but not the end of the journey. We have developed from a very small program in Flinders Medical Centre, we're now starting a statewide surveillance recall program. It's a cancer prevention service with a very strong consumer focus. We're integrating it really well with research to make sure we've got that research infrastructure to lead to further ideas. And this will ensure that the right person gets the right care at the right time. So from little things, big things grow. We started off with a very small idea. We launched this idea across the state. But we do know over the next 15 years, there's going to be 3 million new cases of colorectal cancer. So we now need even bigger ideas. Our next step will fix the world and will be bigger than PayPal. I'd like to thank everybody for listening and for all of the team, a huge amount of team members over the last 24 years, the nurses, the admin, the clinicians, the research staff. I'm just presenting on behalf of them today, and I'm very happy to share this journey with you all. So thank you very much. And I will just put up for any audience members that happen to be gastroenterologists or surgeons or GPs or online members, we do have a survey where you can contribute your thoughts in relation to what sort of screening tests are best for patients instead of colonoscopy. So thank you for your time.
Thank you, Erin. That was fabulous. Really amazing to see the work that's evolved over the 20 years. And I think what I found particularly exciting was right in the middle there. You said, oh, and by the way, this is informing all the international guidelines. That's something we really need to celebrate more and more at SALHN. We're doing so much good work, and knowing that we, a little place like us has been able to influence worldwide is actually quite remarkable. So well done to you and to all of the team. It's quite phenomenal effort. Obviously, we'd like to open up for questions now for Erin. Anyone in the audience would like to say? Do I need to just go along a slide? I hadn't seen anything pop through on Slido when I'd checked, but we'll keep an eye on that. Does anyone have any questions right now for Erin? Oh, yes, there we go.
Excellent talk, thank you very much.
So we'll just run the mic up.
That one's on? Yep. Excellent talk, thank you very much for that. Quick question, something that might be really acceptable to consumers these days is possibly a genetic test, which might actually, give you some really accurate results about, prediction about future cancer. Have you thought about that at all? And, there's pretty good online databases now that can, cross-check genes.
Yeah, and that's an excellent thought there, and it is work that we are looking further into. So Jean up the back there is a very excellent basic scientist and has looked into the online databases with the mutations present. And Molla, who's a clinical epidemiologist in my team, he's looking into some of the modifiable risk factors as well for these individuals who end up developing precancerous lesions, to see if we can identify some of these risk factors. But when it comes to genetics, with bowel cancer, the majority are thought to be just random, just bad luck, a small proportion. So I think about 5 to 10% can be explained by Lynch syndrome, where the genetic changes have been identified. There's going to be a lot more genetics out there that we're not aware of, and SNPs. that could explain some of the risk factors. And so, yeah, I think as we get cleverer with technology, we should be incorporating all of this information into really personalising surveillance. Someone with risk factors should be having colonoscopies more often compared to individuals that may have had a family a family member with cancer, but they might not have the same risks themselves. So, yeah, I do love the idea of really personalising care.
Vlad? Okay. Thanks, Erin, and thank you. She's my neighbour down the corridor, so I'm basking in her light. I've got a question whether that results from the SCOOP program can be used as a training or surveillance for the doctors that are actually performing the colonoscopy. So there is a certain a measure like a polyp count per surgeon performing the colonoscopy. Is that data being considered to be used for the surveillance and the training of the quality of the colonoscopies that are happening?
Yeah, that's a great point. And we actually started doing that. We changed over our system in 2021 where we started collecting a lot more data because we wanted to collect not just the surveillance colonoscopies, but all of the colonoscopies happening in SALHN, because then working with the quality team in Flinders, so Luke Betts, we can provide that data to then do the quality measures, which he then feeds back to the individual clinicians, because there are benchmarks in place. Doctors doing most of the scopes should be able to detect around, I think the adenoma detection rate's around 35% or so. There should be a certain benchmark of how good the colonoscopies are, the cecal intubation. And so all of those measures are now being collected. We've been doing that for the last 2 years. But by having this big system across South Australia, we can then ensure that the same quality is happening in all of the hospitals, all of the public hospitals. So, and there's more. We can also discover, by having big data sets, we can discover other quality measures that might not have been reported that we find are predictive of how good the colonoscopy is. Because if the colonoscopy is not good, then there's a risk for cancer later. So we can make all of those correlations by having the data.
We've now got some Slido questions, which is exciting. So if we look at those, the first one that actually popped up was, how many colonoscopies do you need to save one life? Can you answer that one?
That's a really good question. We have the data that we could look at to answer that, but I'm not sure what the answer is off the top of my head. It is, what they find though is in America they do screening colonoscopies. So instead of doing the fecal test, they generally send everybody for colonoscopy once they turn 50. Now, from the Cancer Council, the Daffodil Centre in New South Wales, they did some modelling to see if we were to do colonoscopies like that in Australia. Yes, it picks up more things than the fecal test might, but is it cost effective? And they found it was very costly. It was not the best approach to do. So we do need to consider, when looking at, how many lives can be saved by doing the colonoscopies, we also need to consider the costs involved as well. But I'll research that and come up with an answer later.
And that probably refers to that last question there as well. What's the cost benefit? And clearly it's more beneficial than doing scopes for everybody, like you've just described. But yeah, you've got a further answer to that or something to look at.
We now have a couple of team members from the health economics team who are working with us to answer that exact question. But by ensuring that we don't do colonoscopies too frequently and we're reducing the risk of cancer, that's where we've got our cost savings.
Yeah, fabulous. Get the update next year, I think, would be great. And I guess the top one's really good. We've obviously... the work that's been done through SCOOP and the international influence it's had, how can the team then influence more industries to take up similar processes and to drive the similar sort of model of care to reduce cancer in other areas?
Well, what we're hoping with the SCOPES program is that the software that we develop will be suitable for other systems within the hospital. The projects are starting, but part of this will be to meet with the other groups in the hospital to see what systems they're using, what the needs are, to try and get a process that could work across multiple cancers. There's other cancers that need, people at risk for cancer that need regular surveillance. We could ensure that there's a model suitable for everyone.
Do you think there's a risk there? Sorry, I'm sort of got into a conversation. Do you think there's a risk with turning it into a computer-generated thing and losing the impact of the nurse-led surveillance? As you said, with the private system, without the nurse, the rates weren't taken up as well. Is there a risk there in changing it from people to computer?
We'll always need the nurses. We have Kalinda in the audience here, and there's always that patient care aspect which is needed, and they will be. There's some complex. While the algorithm will help streamline some of the system, it won't replace the nurse-led process. And this is, a part of the process that is working really well with the consumers. So we won't get rid of that.
I think we've got another question right up.
Yes, so I haven't got a microphone yet, but can I say I was very pleased to leave the United States before I turned 50 because all my colleagues were going for their colonoscopy at that time. Okay, so I've got two comments. The first comment is, based on the cartoons you showed, have you considered the confounder that the docs are mostly men and the nurses are mostly women? Anyway.
That is a good point, yes.
In looking at the effectiveness in follow-through, right? That was a joke, actually. But I guess nobody
I think you've got a good point, though.
So my question is, in your Scoop program that you're now taking out into the community more broadly, what are you going to do as the guidelines change, and how are you going to, where are you going to implement that, and how are you going to survey for changes in the guidelines, and what's a significant change in the guidelines? So can you just talk a little bit about how changes in the guidelines are going to affect your project?
Well, the guidelines do change. So there are some changes coming up very soon in the surveillance guidelines. The last set of guidelines were published, I think, in 2018. The set before that was 2011. So there's often updates to what's recommended, such as with when should people start surveillance if they've got a family history of bowel cancer, how soon should we bring back someone after a small adenoma? So we have to ensure that the system can cope with change. And sometimes the guidelines don't have the evidence behind them. And so by having this huge data registry, we may find something that, the guidelines might say 10 years is fine, but our data from all of South Australia may say 5 years is safer. And so we need to have the flexibility within the system to allow for this change. It's going to be a challenge that we need to make sure we get this right.
Thanks very much. I really enjoyed your lecture.
Excellent. Are there any other questions in the audience? I think the last one was something of interest, the average age into the Scoop program, because I think with the advent of news and the social media and all those things, we're seeing more and more people in these forums talking about very young people with bowel cancer. And I think we all feel that there are more people being diagnosed with bowel cancer at a very young age, 20s and 30s, which is, 10, 15 years ago, it was a very rare thing. Have you noticed a change in the demographics?
We have, yes, and definitely with the bowel cancer diagnoses. And we work with consumers who've had bowel cancer. One of our consumers was 33 when she was diagnosed with bowel cancer, and she helps inform our projects to ensure that we're doing the right thing. I don't have the actual numbers, but we are looking at, the different demographics over the years and what's been changing in the Scoop program, how the findings have been changing, how the demographics have been changing. But I feel that we are seeing younger individuals, and that's why it's really important to make sure that we keep, if they've got 40 years of colonoscopies ahead of them, we make sure we get it right for them. We need to reduce the cancer risk for everyone. And I see there's a question about a blood test. That's a really good question, because we are doing a lot of blood test work, which is why I wanted to answer this question. What our surveys show is that people like the idea of a blood test over the stool test. We give them the options of, what would you prefer to do? If there was a blood test for bowel cancer or a stool test? And I think about 3/4 of them say, I'd rather do a blood test. But then the reality is they have to attend a phlebotomist to actually get that blood test. So if it was incorporated the right way into GP care, then the blood test, I feel, would be more acceptable than the stool test. But the stool test is currently the best way of picking up these pre-cancerous lesions. So anybody, when they turn 50, make sure you do that free bowel cancer screening test.
Excellent. I think we probably do have time for the very last question, and I think it was interesting to see the difference with the private patients, and I think our SALHN public patients are being cared for extremely well in this service, and it's something we should be very, very proud of as a network. But how do we encourage the private sector to provide the same level of care?
We do have a very good relationship with with some of the private hospitals. While the Scopes program is starting off as a public hospital rollout, I don't think it should stop there. I think we should bring it into the private sector as well. We need to make sure we get all of those doctors on board and get this is part of setting up an appropriate system that will work for everybody, public and private.
I suspect the patients will start demanding it too once they,
I hope so.
Okay, I think that's probably the end, unless there's any last question from the audience. Oh, there we go. We do have time. So, how's your data collection changed over the years? Do you wish you'd collected other things, more data?
I'm very data greedy.
Yes.
Anytime one of the team says, do you think we should collect this? I'm like, collect everything. But we have got ethics approval to start collecting lifestyle factors. So we'll soon be sending out surveys to get food frequency diaries and sleep habits and physical activity and alcohol intake. All of these, we're working with Moller's project to get the modifiable risk factors. And as new discoveries are made in research, it also makes us go, we should be looking at this as well. So by having a system that we're not doing the data entry into, but it's pulling from GP systems and from hospital clinical systems, we'll have access to that data that's all linked to the patients having the colonoscopy once we get ethics approval, of course. And so this can inform, better research.
Well, thank you very much, Associate Professor Erin Simons. Please join me in thanking her for a wonderful talk this afternoon. We'll just get set up for the next round of speakers, which will hopefully head down. Is that the same? Just leave that one up for a minute. I think we're ready to roll with part 2 of this afternoon's session. And now we're heading more into the digital side of the future. We've just seen from Erin the historical, like the last 25 years with the bowel cancer. And now we're going to the digital future. We're going to go on a bit of a journey, I think one that's actually unfolding right where we are already. Technology is meeting patient-centred compassionate care. Data insights, as Erin has said, is just so powerful. And it can help save lives, and when we've got boundless potential for artificial intelligence. So I think this is a really exciting part of our talk today. I'd like to now introduce Associate Professor Niranjan Bidagadi and Dr. Rowan Ward. They're going to talk to us today about the humanisation, I should say, of health information delivery. Niranjan is the Associate Professor of Digital Health at the College of Medicine and Public Health at Flinders and an accomplished leader in digital health research. So welcome today, thank you. And Rowan is a qualified medical doctor, but has also branched out now into his own medical, what have I written down? Medical technology business, bringing a sort of a unique blend to this talk in that, you know, it's got the clinical expertise and the entrepreneurial experience to really take this into the future. So please join me in welcoming our two speakers for this afternoon. And don't forget to use Slido. The questions, it's the same QR code as before. Thank you both.
Thanks, Sally. Great. I'm delighted to be here today, and thanks for the introduction, kind introduction. So I won't get into the details of who I am because of time constraints. So the title, like the structure of the title of my talk is Humanizing Health Information Delivery. I'm sure everyone is overwhelmed with information, so this is really where how do we sort of adapt to this excessive noise and cognitive load. That's what I'm going to talk about. I structured this talk into two parts. First, I'm going to give sort of an overview of the research we're doing in this space with an example project that we're doing in SA with SA Health. I think that's going to resonate with the audience here. And then I'll hand over to Rowan to sort of take us through how we are moving that work we have done in research environment to commercial environment so we can scale it in real world faster. So just before I begin, just want to also thank our supporters for funding our research program, and especially the Barossa Hills Fluorio LHN, who has been sponsoring us for over years, the work we do in our lab. So with that, just what I want to do is give an outline of the problem in the health information delivery space as we see it. At a first principle level, I guess health is a result of interactions by an individual or collective health professionals and institutions in different contexts, of course, across time and space with the resources that are there. And by interactions, I mean these are cognitive decisions, cognitive tasks, like how you understand, how you make sense, how you decide, and how you act, and probably also what you omit, ignore. And all these interactions being informational activities, there's always a software or a technology behind them, maybe immediately in front of the interaction or maybe a few steps remote. So it's not a far-fetched leap to say that softwares are mediating health interactions directly or indirectly. Now, the other point I want to make is the advances in technology. Thanks to those advances, we are seeing an increasing amount of knowledge, health knowledge, and so the knowledge is increasing. So is the cognitive load that is increasing. So our ability to comprehend and make sense and act on information is falling behind our ability or capacity to create knowledge. So there's this significant mismatch emerging. And evidently health sector, from what I've seen in industry reports, is one of the largest producers of data compared to mining or all other sectors you can think of, and it uses it in the least sophisticated way. Of course, there are certain niche areas where data is used well, more probably in the acute setting like imaging or surgery, but in a broader chronic disease space, the use is very limited. So against this kind of background, the dynamic we have in health system right now is sort of a dwindling workforce, is human workforce. Is looking after more and more sicker people with chronic conditions and the complexity getting worse. And so the outcomes are getting worse across all levels, the clinical, financial, operational, whichever way you dice and slice it, there are challenges. So to really bridge this gap, so as we're sort of bombarded with this kind of excessive information, what kind of adapters do we need to build so that we can utilize this information, medical knowledge in an efficient way? How can we overcome that noise? So this is sort of the core focus of our research. And inevitably, what we need to do here is to rethink the role of softwares and technologies from being support actors to critical actors in the decision-making process. And this is what we are doing. So in essence, we are building the next generation information delivery mechanisms for all users of healthcare providers. And I say building, really there are two stakeholders here. There is the technology that's delivering the information. There is also the information itself, the medical knowledge. And then there is the end users who are consuming this information. So it's a very conflicted area with different priorities in each of those, for each of those stakeholders. So we are really trying to understand the problems that arise when you try to converge these three things, both from a technical end as well as end user end, and create solutions. We're working across a number of projects in a number of clinical areas, both consumer-oriented as well as health professional-oriented. So I won't have time to go through those. So what I'll do is I'll quickly take you through the project that we have been doing with SALHN. This is to set the context. This is a project that was done with chronic mental illnesses population. So that's approximately 3% of the population. They do have they need ongoing care from different parts of the health system for different times. It basically boils down to the sequences of medical appointments, scripts, tests that need to occur based on the condition and the changing circumstances. And this is quite a data-intensive task to align them, and all the data is there, but the data is not curated and available to health professionals who need to act on it. So in a mental health sector, the workforce, there are workforce issues. Information overload is causing that staff retention and burnout challenges. And I'm sure you replace mental health with any chronic disease, it's probably a similar story that plays out. So what we did is to really understand how this problem better, we did a time and motion observation of mental health workforce from using an ethnographic approach. So it sort of followed 54 people. And this is how a typical mental health professional spends their time. 40% of a day is spent sifting through the EMRs, pulling data from 5 different systems, then putting it in spreadsheets, computing some parameters. And so that's really the decision-making part. Who should I see? What should I know about them? And then another 40% of the time, they're actually acting on it, following up with other professionals. And there's only 20% time of interacting with patients. So this is a kind of workforce dynamics that is currently in play. So what we wanted to do here is we started to think that 40% time they're spending on data processing, could we replace that could we bring in an algorithmic workforce to take over that job? And so that is what we have been working on. So we put together this solution called Care Mapper. It's in the simplest terms, it's a plugin that sits on top of existing health data sources and sifts the data on behalf of clinicians to help them with better decision making. So the clinical decision making, give or take, in a sense, boils down to 2 things in these contexts. It's really about knowing which group of patients should I be paying attention to, either to review or to discharge or to follow up at any given time. And when you're with the particular patient, what do you need to know about that person before you interact with them? So these are the 2 type pieces of information. And these are essentially data tasks, data sifting tasks, and an algorithm can do that job. And Care Mapper solution we built basically uses algorithms to workforce to do this data sifting on behalf of clinicians. So we have deployed this in mental health. and we have had good uptake and success on it already. Just to add on to that, how it actually works, just to elaborate that a bit. It's a platform agnostic solution. There are 3 components to it. Firstly, it ingests data from different sources, not just the data that's within SA Health, but also data from My Health Records and other jurisdictions. And then there is second layer, a suite of algorithms subject matter experts can configure. And so those algorithms will troll or sift through that data to look for insights. And it only relays the insights that you need to know as a clinician using minimalist interfaces. So there's like 3 layers we have really worked on. The journey so far, it has been built ground up, really, not from a top-down approach. So we have done a lot of co-design, prototyping, deploying it, learning it, and then upgrading it. And a lot of everything we have done so far, it's all published. So we did a demonstration trial, and we published those proof of principles as well. And since at this point, it's at a stage where it's sort of really built to a commercial grade so it can scale up. There are 3 things I want to sort of share here, which we learned through this journey that probably is relevant to, I guess, humanizing this information delivery. The first thing is when you do use algorithms to, when you outsource some of the decision support capability to an algorithm, inevitably algorithms will create signals that require more action, and often they can create more work, as algorithms always work on a binary kind of proposition. So what we have done here is to try to understand how can we improve the sensitivity of algorithms, and in order to do that, it's not really the modeling that is missing. It's we just don't have the data around the clinical decision making. What we need is the labels around a particular decision that you decide not to act on, and the reason why you don't act on, and that's not collected in EMR systems in any way. So we have updated this system to sort of really capture that kind of information that can help us to teach these algorithms to get better over time. The second misconception that often exists in the medical record EMR paradigm is the impact of an analytical tool is measured based on how many people are using it or interacting with it. But in an information delivery context, not everyone needs to log in and use the tool. You can restructure the workflow where few people can interact with the tool and they can then relay it to other users. So in this trial, in our work in mental health, we were able to re-architect the workflows in that way. And the third thing is when you use algorithms, there's always going to be contextual information that sort of change the accuracy of what you're predicting or you're detecting. And a lot of that is related to the patient's state and perception at that point in time. So there's always a need to bring in a consumer channel into this, consumer carers, to feed into the algorithm pipeline. So that's the third thing we have also built. So where we are at right now is, so we have sort of done the trial in mental health, and we're sort of now transitioning it so it can be used in mental health in a routine use. And in parallel, we have got other projects underway in other areas, including an MRFF funding we recently got in medicine safety, in aged care, in chronic diseases. So as we transition it from research environment to this deployment environment and run multiple projects, it sort of we face these problems that are outside the traditional paradigms of what we can do in a research setting, and hence this is where Rowan can sort of take over and fill you in on how we are supporting this transition from small research trial to a larger scale implementation.
Thank you.
Okay, thanks, Niranjan. So, my name's Rowan Ward, as I've been introduced. I'm a trained clinician. I've recently been appointed as the Director for Business and Commercial Development for the Flinders Digital Health Research Lab, working with Niranjan. I trained as a clinician here in South Australia. I worked in Queen Liz. I did a couple of stints here at Flinders and the REPAT. But I had an idea and a bit of an internal geek to me that I could put together a computer package that might be able to help with my ward rounds, which I did. Part of becoming a surgeon, you have to suck up to the college, and so I started a master's looking at how that software might actually help in workflows. I never completed the master's because Geelong Hospital at a conference reached out, wanted to acquire the software, so I had to work out how to commercialise it. 17 years later, I sold that business to a public global US health tech firm. Worked for 3 years running their Asia business as part of my earn-out, and since COVID I've been rattling around Adelaide looking for things to do. So, what's CareMapper? CareMapper is a platform, as Niranjan's explained. We ingest large volumes of data, we apply machine learning AI algorithms to generate clinician insights, and then we present them in a workflow that allows clinicians to act more quickly, more effectively, or with less effort. We've concluded a very successful research trial. We have stable technology, we've got a very engaged clinician user group, we've demonstrated our outcomes, and now we have a customer that's looking to use it. And how do we get there? So at the end of a research trial, everything else you've done, what you're left with is a product and some users. Where to next? So, process of commercialisation. We take our product and users and we set up corporate infrastructure. Legal, IP, asset management, financial accounting, compliance, business plan, marketing plan, capital strategies. This is one that is quite important for all startups. Do we fund ourselves? Do we take on capital? Do we sell? Do we reach out to the 3Fs, the friends, families and fools investors? Not my favourite. Having designed a business, we now need to sell. We need to work out how to sell that product. We need strategic planning, a marketing strategy, market segmentation. Need to decide if we're going to find a customer for our product or find a product for our customer. Both of them work. They don't work at the same time, but either strategy can be effective. We need to start looking at engagement and relationships with different parties, our customer market, our industry market. These are different than what we would have experienced in research. And we need a sales operation team. That requires bringing in staff, dealing with procurement, tenders, pipeline management. Do we sell things at a loss to start with? Now we've made our product, we've made our sales strategy. Before a customer's going to buy, we need a support process. How do we know that when we hand over the keys, the product's going to continue to work? That requires support infrastructure. We need help desk, ticketing system, user guides, admin guides, change management, product roadmap, client advocacy, making sure that the product meets our customers' current and future demands, making sure the product keeps working, make sure the product continues to work with the changes in the infrastructure that are created. We need to make sure that we meet all our privacy, security, audit, all of these things that aren't necessarily captured in a research process, but are definitely required in a commercial operation. And finally, we need to make sure that our product is scalable to suit our marketing and business strategic objectives. And finally, we need to make sure that we don't lose touch with the original thing that drove the product, which is the research initiatives and development. We need to make sure that we can commit ourselves to a research approach. For CareMapper, we're continuing to work very closely with the Digital Health Research Lab. We'll be looking to encourage their ongoing research and also to facilitate that research into new commercial opportunities. We need to bring in staff. We need to make sure that that staff can support the product and continue to develop the development. And we need to make sure all of this can be done within the context of our commercial strategy, our marketing strategy, our sales strategy, our support strategy. It all needs to be done in concert. So there are lots of things that need to happen around a product before you can even begin to make a sale. And as soon as you make that sale, you're then stuck with having to look after the sale. And so there's a lot of thought that needs to go into that. That's a role that I'll be playing with Niranjan and his team, specifically with CareMapper, but also looking for other commercial opportunities, whether that's trade partners for future research or you know, any angle that we can see to get the research into the hands of real users. So what's next? Well, we're continuing the research. As Naranjan's pointed out, there's 3 major grants that are already underway. There's a number in the pipeline and certainly more that we're expecting in the future. And so our commercial entity will be creating a platform where that research can continue. We've moved from a research trial phase to a commercial customer phase with the same group. And so structuring a business so that we can go through their formal procurement processes and licensing and creating ourselves as a financially independent entity out of that research is also really important. And finally, we've created an open architecture. We believe that there is significant potential for future research that takes the extraordinarily large volume of data and the extraordinarily time-poor resources in the clinical environment. We believe there's research out there that will continue to generate opportunities to improve the way that healthcare is delivered and the clinician experience in doing that and the patient outcomes. CareMap is a platform that takes large volumes of data, My Health Record, Sunrise and future EMR data. It offers endpoints for algorithms to interact with that data, to generate insights, and it offers a platform to present those insights in a way that makes sense with a proven clinical workflow that doctors, nurses, allied health and patients all use. We've worked through our commercial, we're getting the wind up, but we've gone through the process of creating a business that can deal with that. And so I guess I'll close by saying we're keen to talk with anyone that has something that they think might fit that bill. And thank you very much for your time.
Just because of time, and I did give you the wind up, as you could tell, I was checking my phone. We're going to get our next speakers up and then do some Q&A at the end. So I might just get you to take your microphones off, get Josh and Stephen up, and then we'll do it at the end. So while everyone... registrars, who has done his PhD in the clinical application of machine learning in stroke, particularly in general medicine, and Josh Kavor, who is one of our surgical residents who's currently undertaking his PhD, basically challenging the traditional approach to discharge and trying to set some criteria and predictive models about discharge of patients, particularly from general surgical units. If anyone's on LinkedIn, these two pop up on my things all the time, so you will see them keep popping up, and really good and engaging talkers. So thank you.
So AI, the fact that you all know instinctively that that means artificial intelligence just alone shows how important AI has already become in modern society. And I think if we had to pick a technology that was probably the most powerful technology at the moment, I would say that it is AI. And I think all of you would probably agree that it is AI. However, with great power, as the great saying goes, comes great responsibility. And there's a lot of genuine fear within modern society and also within healthcare that AI could actually get out so powerful that it gets out of our control. And essentially there is real civilization level risk that if AI is not researched and not worked on properly, that these fears could be realized. This, as many of you may know, has caught sort of global attention. And these fears are pervasive throughout modern media and up to the highest levels of government. This is a photo from the US just about a week ago, where they've had really serious discussions about how AI can be controlled, how it can be managed, and how it can be harnessed to benefit all aspects of society. This is also occurring locally. We got invited by South Australian Parliament to talk on and also give some advice about how AI can actually be used to benefit healthcare. And our main message was that if it's researched and if it's harnessed properly in a measured fashion, not only can it benefit healthcare spectacularly, but these risks and a lot of the fears can be averted. So what can it do? To summarize, AI is the most powerful tool that we could potentially deploy across healthcare. And I think it can actually cause or result in a lot of benefits in pretty much every sector of the healthcare system. Just some examples that many of you may be familiar with. AI has grown to a lot of prominence in developing art. Just on the screen here, if you ask AI, what does a hospital of the future look like? That's the image it generates on the left. Then moving to the right, if you ask it, what does a cat interpreting an MRI scan look like? That's what it spits out. Then moving to the right, if you ask it, what does a neurologist look like? That's what it spits out. And then finally, if you ask it, what does it look like when an evil AI is scheming to take over a hospital system? That's what it spits out. Also, AI, and I'm sure pretty much all of you have used ChatGPT, is extremely powerful for building models and also for the analysis of the plethora of information that we have at our disposal now, particularly given the fact that we have electronic medical record systems. So AI and ChatGPT can actually generate or advise us about coding. And then it can do the generation of the coding for us, albeit it still does need a lot of edits, and that's where the human retains a prominent and important role. However, also important, aside from the actual work and the actual interventions that we're using AI for, AI does grab attention, and that actually is a really important thing. AI is currently a prominent focus of the top medical journals around the world in all sections of healthcare, and it's also in great interest of the media. And that not only includes newspapers or news outlets, but like all aspects of communications within modern society. We've felt a lot of the benefits of this, as a lot of the work that we've done in AI, and we've done work with AI in pretty much all aspects of the healthcare system, or most aspects of the healthcare system, we've gained a lot of traction from the work that we're doing. Journals do have interest in AI-related work. So why is this important? Because the most important, or the most sort of effective use of AI is that it can benefit patient care. And AI actually aligns with pretty much all of the goals within SALHN's strategic plan. Like, we're in SALHN Research Week currently, and there's so much fantastic work that's currently being done and should be celebrated. Not only can AI benefit all aspects of this work, but it can also benefit the communication and the interest in all the great work that's currently being done in SALHN. If we look at the 4 fields of inquiry, that is the discovery science, the clinical trials, the continuous improvement, and also the health services or health systems research, AI can actually benefit every aspect of all those fields of inquiry, and that's a very important thing to keep in mind.
So we've heard about what AI can do. What about what it cannot do? And this is where the healthcare systems perspective is very important, because we work in healthcare. AI does not operate in a vacuum. It operates in our healthcare system. And we have to realise that and build that into how we use it, because there are things it cannot do. So there are finite resources in healthcare, and we need to use them intelligently to provide the maximum benefit for the most people possible. If we run out of tenectoplays, AI cannot give me more right now. Now, it can affect supply chains. At some point, it might fly a drone to bring me tenectoplays. That would be neat. But right now, if I'm out of blood products, AI can't give me more. Similarly, space is a finite resource. It can influence how we manage beds or operating theatres, but if the hospital is out of beds, can AI make a new physical space for me right now to put a patient? No, it can't do that. You have to plan ahead. Similarly, staff. You can talk about things around, helper robots, all that sort of thing, but ultimately, can AI make me a new human being who can perform this role right now if the neurology registrar is sick? No, it can't do that. It has to operate within the healthcare system. And this has been touched on a couple of times, but time and financial resources are also finite. If clinicians are here for 12 hours a day, they need to use that time most effectively. And if they spend all that time clicking through prompts and closing windows and closing pop-ups and opening things and reloading a window that they just closed, which is really sad because it took 30 seconds to open an outpatient's, that's time that doesn't get back. And you've got to use that finite resource as effectively as possible. And it's in this context we need to think about how we can use AI to improve our healthcare systems. So what's happening now? So we have perspectives on this, and we're trying to prove it through evidence. We've got a few projects that are hopefully going to be demonstrating areas in which AI can improve our healthcare systems. So coming up with study names is great fun. It wastes too much time on it. ChatGPT can probably help with that. So the first one was a stroke one. That was looking at when people hit the door with a stroke within 24 hours, can we predict aspects of when they'll leave hospital? Like, how long are they going to be here? Where will they go? Will they survive to leave hospital? And also, what will their level of disability be when they leave hospital? And if you give that information to people within the first 24 hours, does it influence things? And it does. So we showed that it reduced length of stay. Didn't change where people went, didn't change mortality, didn't expect it to, didn't want it to, but did reduce length of stay. EPAS-ML. I enjoyed that name. Other people don't find it as funny as we did, though. So this one is looking at penicillin allergies. There's probably multiple people in the room who think they have penicillin allergies. Often, if you think it's not actually true. You may have had just infectious mononucleosis or something at the time. That's why you got a rash. If you come to the hospital with sepsis and you need Tazocin and you've got a penicillin allergy, your admitting doctor is going to come across a conundrum. Might look at Venk and ciprofloxacin or something. First-line antibiotics are important. So we're looking at, can AI go through an electronic medical record and find people who have dud penicillin allergies? There are people in SALHN right now who will have an allergy that says penicillin, reaction, UTI. Really? The allergy to the antibiotic was the infection it was treating, and that's recorded? Yeah, it is. You don't even need to do a penicillin allergy challenge to remove that. So what we did was we made an algorithm, it scanned the EMR, it found people who had these dud penicillin allergies and sent emails to the doctors treating them to say, hey, have you thought about evaluating their penicillin allergy? And we found that, surprise, surprise, people who received the emails, or the doctors who received the emails, the patients, had more of the penicillin allergies removed than those who didn't receive the emails, where it's just carried forward in perpetuity. We've got the second phase of the study going now, where someone's actively going to the patients and trying to delabel them. We'll have results from that before the end of the year. The IMPEDE-ML, so this is about discharge planning. Again, I thought the study name was amusing. This is about predicting when people will leave hospital. Obviously, this is very important to patients, families, transport, nursing, healthcare system. Now, this is one where it's reading the notes. So it picks out obvious things like discharge tomorrow. Great. But I also see things like nausea, vomiting overnight, discharge tomorrow. Are we sure? It can do a reasonably good job of this. And now we're evaluating whether that can actually help people plan when they're leaving hospital and ease that process. Edifice is an endocrinology one. So I'm sure if there's doctors here, they remember calling the endocrinology registrar. You sit down, you go through all of their BGLs, every dose of insulin they've received in the hospital, and now you've got SGLT2, GLP-1, all those acronyms. So this one is looking at informatics and machine learning to proactively instigate endocrinology consults. So this is where endocrine gets a flag to say, hey, this person's BGLs have been 25 for 2 days. They might need an endocrinology consult. That one's ongoing. And we've got more coming soon. So epilepsy surgery, identifying people with drug-refractory epilepsy who might benefit from surgery, who haven't been referred, and then the Adelaide score, which is one of Josh's initiatives, which is looking at facilitating the discharge process in general surgery. And this one has got a fair bit of attention. Josh has got a video for his 3-minute thesis, which made it to one of the finals at that QR code. This one is going to be implemented in the very near future, hopefully to have results well before the end of the year, actually, probably by December. And then there's audits. Audits are important. So we do research to develop new interventions that will improve care, but we need to check that they're still working well. We need to check that we're adhering to standard practices. We heard all about it with colonoscopy earlier today. Audits are time-consuming. You know, TMOs sit there on their weekends, after hours, trawling notes, just to see that everyone got their Keppra on time. So we now have a statewide system that's automatically auditing neurology admissions for status epilepticus to make sure that we are following evidence-based protocols, which we have.
And this is particularly important in SALHN. I've been really fortunate this year to actually be involved in SALHN's continuous improvement program and learn about the culture of continuous improvement that's throughout SALHN. And while there is a fantastic framework that has been developed here, we can know that this new technology of AI can actually be implemented at every single one of these steps within SALHN's continuous improvement framework. If we just take a look at the overall steps, defining the problem, AI can help with that. Breaking down the problem, AI can help with that. Setting a target or like defining what our actual mission is, AI can help with that. Looking at the cause, looking at developing the interventions, implementing the interventions, assessing the impact, and then of course, like figuring out new potential ways to continue that improvement into the long term, which really typifies the ethos of SALHN's healthcare system. Of course, healthcare improvement or continuous improvement starts even before entry within the hospital system. And we've shown that within medical education, both at the undergraduate and postgraduate level, that AI can actually benefit this as well. One of the studies that we've done that shows how powerful this is we took an analysis of AI's capability at sitting the Australian Medical Council or AMC licensing examination, and the gist of it is that it does decently well and it can pass it. However, it's important to note that not all the algorithms are the same. If you see on the screen at the bottom is the accuracy, and there are varying levels of accuracy. I want you to pay attention to the fact that there are differences, not really to the individual models themselves, and this will be a trend that will continue into the long term. And to just emphasize the point that each model, let alone the large language models or different types of AI, there are differences within each one of them. So this is another study that we've done looking at some different large language models. And just in the summary alone, you can see that the data that feeds into the algorithms differs, most importantly with regards to the time frame of the information that flows in. Also, it differs with regards to its availability on the internet and also its connection to the internet as well. Also the types of data that are actually inputted into the algorithm, the extensions available, and where the server is located.
So from a healthcare perspective, we've now heard about what it can do, what it can't do, what's happening at the moment. So the obvious question is where to next. Now, we have a lot of leaders in various fields in the room who will be very influential in this process of driving AI in healthcare systems. And we have some things that we think are very important just to raise as topics so people can bring them forward into their subsequent meetings. And we'd be really interested in your thoughts as well. So the one that's always at the forefront of a lot of people's minds in healthcare is cost. Now, the healthcare system is always operating at a very high cost and always near the upper limits of that cost. Now, can AI save money? Probably, it'd be great, but we need to be careful because we've got a picture of a nice car here, and there's probably some people in the audience who drive a car like this, and you buy one of these cars, and yeah, it's a reasonable upfront cost, but it's going to pay itself off in the long run. German model, it's going to last a long time. But what about the upkeep? I can only get it serviced in one place, and every time they charge me how much? Oh, right, okay. And how often do I need to get it serviced? Oh, right, really? So I paid this much for my AI model, and now I've got to pay this much in upkeep? Well, actually, I probably want to change models now. I'm going to go to a different place to get my car serviced and get my AI fixed up. Oh, wait, really? I can only get it serviced at the same place that I bought it from? Oh, really? Okay, I guess I'll stay there forever. And oh wait, now I've got these frequent services for my AI product and I can't leave and I'm locked in and I'm now dependent on my car to get everywhere I need. Right, I guess I'll stick with it for the long run. That's the sort of process that could happen with AI, particularly with the lack of interoperability, which is why we need local expertise as well to help drive these processes. Another commonly phrased benefit is that AI will give clinicians more time with patients, every aspect of healthcare. It's possible, but we also need to be realistic, which is if you have a clinic that's already running 2 hours late and you have AI that makes part of this more effective, is it actually going to give you more time with every patient, or is it just going to mean that you get less time for each patient and you get more patients through? I mean, that's still important, but we need to be realistic when we think about this panacea where we get to spend the full half hour of our appointment with the patient and the algorithm writes our clinic letters for us. And realistically, is that clinic appointment just going to get shorter and shorter and shorter? We need to think about that ahead of time. Now, we've spoken about education. AI is going to have an increasing role in education. We need to think about the implications of that. Now, this is really fun, where you can get AI to pretend to be someone. It's like, medical students, They have to do histories with pretend patients. What if they could do it all with a chatbot? They could take histories from anyone with any pathology. You know, someone who's just returned with a fever who has malaria, you know, can get someone to portray that through an algorithm. And it's pretty neat. This is one I did. Someone's coming to the hospital with chest pain. You know, they've got a reasonable history of chest pain, makes sense, sounds like ischemic heart disease. You can ask them for their background, investigations, gives you some American medications actually. But then, yeah, it starts to come up with things like, oh, my heart rate is elevated and it's irregular. Well, that's interesting, it's irregular. What does your ECG show? I reckon I've got it here. My ECG shows that I'm in rapid AF. Oh, damn, it knew what I was trying to do there. Okay. So it's pretty good, but it does get things wrong. And the question is, if our medical students and other healthcare professionals learn from AI, what will they learn? They will learn to practice like AI. Now, systematic reviews, meta-analyses are vitally important to medicine. We don't have time to read everything that comes out. It's just a fact of life. If we get AI to summarize information for us and we do not read that fundamental material, our views will be based upon that AI summary. Now, if subsequently a patient asks AI, hey, are arthroscopies really important for my knee osteoarthritis? And AI says, yeah, they're vital. You definitely need knee arthroscopies. And then you ask the clinician says, well, I asked AI as well, actually. I read this review that it made because it summarized everything for me. Yeah, it seems important. Where does that critical appraisal go? We need to be very careful how AI is used in education. And ultimately, we need to work out, should it influence our practice now? I mean, this is a question we have to make every day right now. And there are checklists for this. We've put one together. We won't go through everything, but thinking about the ethics, the cost, and also the evidence. We have to come back to evidence. We hear about research, we hear about evidence. And this is a slide that I try and include in every talk that we give. If you forget everything else we said, remember this slide, because accurate algorithms do not necessarily improve outcomes. We need to show that. You can make a very accurate algorithm that improves nothing. If it predicts something blindingly obvious, well too late, or it's very accurate, but the false positive rate is still too high. We need evidence to show that these algorithms improve outcomes in our healthcare systems before we use them at scale. So this is a question we'd be really interested in all of your thoughts in. It's something we stay up at night thinking about, which is how can we make algorithms right now that improve our healthcare systems and our patients' outcomes? So I know that there's some fascinating work going on with my home hospital in SALHN. I think that there's many opportunities that would be similar, and we'd be really interested in all of your thoughts if we have time.
Sorry. Oh, I think that's amazing. Thank you both. I think two very impressive comments. Thank you. But we will steal a couple of minutes. I apologise, Amy and Lauren. We're going to go into the changeover time. Can you just forward on the slide and we'll see if any Slido questions have come up. Okay, we'll wait there. Has anyone in the audience got any questions? I think two fascinating talks about what is coming and what is here, more importantly, and how it can benefit us all. So, any thoughts from the audience? Yes.
Thanks for the talk. My question is for Stephen and Josh. Yesterday, I was in this same lecture theatre and I heard about the issues that are around translating evidence into practice. I wonder, do you think is there a role for AI in translating evidence into practice faster than what's currently happening?
It's an interesting question because I think that, I'll answer the question in a minute, but one area where translation works terribly is AI. You look at the number of studies where someone's made an algorithm, the algorithm works great, and does it ever get used in practice? No. There's a whole literature around that implementation translation gap in AI. Whether AI can improve that translation process, I think so. I mean, I haven't tried to do it myself. I can think of a few ways that you could, even at just a kind of background level where, you know, it helps with editing things, helps with emails. You can think from a logistical standpoint like that, it's going to facilitate that process in some way, shape or form. But at a more institutional system-wide level, I'd have to think about it. I think it's a really interesting question. Do you have any ideas?
No, absolutely not. That's why I asked you. But I just know that the gap between the evidence being generated and the practice actually changing is so long that I wondered if there was a way AI could perhaps, you know, present the evidence to clinicians more easily so that clinicians could incorporate that into their practice quicker than, I think, 17 years is the figure that I heard yesterday.
That'd be cool, like automated audit. Your practice doesn't match with the current standards, therefore you get individualised prompt via email.
Yeah.
Could work well, could be really annoying.
Yeah,
Thanks.
I think one benefit is that AI can actually improve the speed and efficiency of the information synthesis at each step of the way. So that could be one way where overall the path towards actual translation realises a bit quicker, maybe.
I'm going to put in a plug-in for continuous improvement, actually, because of the same processes. If you're always improving, you know, when you're evaluating, you then go and look at the research again, and that's a quicker way to then update what's actually going on. So if you're looking at your protocols, your guidelines, etc., if you're always doing it, you're going to be checking the evidence body quicker, and AI is definitely going to be able to help with that if it can collate it in a sensible way that we can trust, though. Yeah. Yes?
False medical information. There's so much false information out on the web and places like. How do you make sure that your sources are strong and good? Any of you?
So a lot of people will propose algorithms to fact check algorithms. Nothing could go wrong with that, right? I think that, personally, I'd be really interested in your thoughts as well. I still think there is always going to be a role for a human expert. You know, we are humans, we need to be able to trust other humans. There needs to be some place you can fact check. I think that that's why the education of experts is such an important area we have to scrutinise very carefully. Be interested in your thoughts.
I don't think I have a good answer to that other than I guess I could probably explain that through how it works in, say, searching online for health information. It's usually the commercial algorithms that sort of serve you, and they're more usually accurate. So on the edges, they have this conflicting interest between what is that you need and what is that drives their goals, which is traffics and clicks. So these are not really technical challenges. I think these are more regulation, political challenges. Who decides whose interest these things are serving? And obviously, some of this has to be tackled at a broader regulatory level.
I'd probably just add for in the Care Mapper universe, we're collecting our own data and then measuring the outcomes of that intervention. And so one of the ways that I think AI models will improve over time is when they start to create normalised and appropriately fact-checked data to train them. It is a bit of a free-for-all on the internet, but that's not necessarily what large language models have to be in the future.
And one other brief thing is that there's some fantastic oncology researchers with Flinders who's doing some great work around disinformation and how it relates to AI, but I'll let them talk about that themselves.
Wonderful. Any other questions in the audience? I think I don't know if that's a yes or no question on the screen, if you want to answer it. You feel like there's a tsunami of applications coming?
I think it's a commercial question. There will obviously be a tsunami of options, and I think it'll get progressively more difficult to find the right one. Hopefully Google will take over and tell us all what we have to do.
Fabulous. Well, thank you all very much for your talks today. Really I really want to encourage everybody to stay in the audience. We've got the advanced studies presentations now. I think it's really important that we support that. So please stay. Thank you.
told that this will probably run into afternoon tea, so if things go to plan, there'll be no afternoon tea break. I'm David Watson, I'm a surgeon. Craig Whitehead is co-chairing this session with me. If I have to dash, it's because I'm trying to supervise 2 operating theatres at the moment. But this is a session where we've got some Flinders University medical students' advanced studies projects being presented. For those not aware, the students in the current medical course have the option of an advanced studies project, which is basically a research project, and look forward to seeing some of their work. So I'll kick off without further ado. Jennifer Pham is starting and talking about can the fecal immunochemical test determine the need for colonoscopy in patients presenting with iron deficiency? Thanks, Jennifer.
Good afternoon, everyone. My name is Jennifer, and I'm a third-year medical student undertaking advanced studies. And today I'd like to talk to you about my research, which is about the fecal immunochemical test and seeing whether we can use it to determine the need for colonoscopy in patients presenting with iron deficiency. So why should we care about iron deficiency? Well, iron deficiency is very common, and there are many causes, but one of the more concerning causes is colorectal cancer. Colorectal cancer can bleed into the gastrointestinal tract and end up in the stools. Sometimes this can present as very obvious bloody stools, but other times people don't even know that they're bleeding in the stools because the blood is microscopic, and this is what we call chronic occult blood loss. Over time, blood loss can cause iron deficiency, and this can be with anemia, and this is what we call IDA, or without anemia, and this is what we call non-anemic iron deficiency. And it's important to understand this differentiation because current guidelines recommend that only men and postmenopausal women presenting with iron deficiency anemia should undergo a bidirectional endoscopy to rule out colorectal cancer and identify any other pathology. Approximately 8.9% of these patients will have a colorectal cancer found at colonoscopy, but a majority don't have any significant findings, meaning that they might not even need the colonoscopy, which is an expensive and invasive diagnostic test. In addition, these guidelines are only for men and postmenopausal women with IDA, which are a group of people that have a high risk of having a colorectal cancer. There are no clear guidelines on how we should investigate iron-deficient patients presenting with a lower risk of colorectal cancer, including premenopausal women and those with non-anemic iron deficiency. So what we need is an easy, cheap, non-invasive triaging tool which can help us identify which patients need a colonoscopy. And one of the solutions is the fecal immunochemical test, also known as FIT, which is well known to be used in the National Bowel Cancer Screening Program for asymptomatic patients, but is being increasingly used to investigate those presenting with symptoms of colorectal cancer. And so my research aims to determine whether a FIT can be used to triage those presented with iron deficiency and determine who needs a colonoscopy most. So for my research, we included adult patients that had a primary care referral for colonoscopy due to iron deficiency or IDA. They all underwent a 2-sample quantitative FIT, a symptom interview, and a blood test. Within 6 months, they all had an upper endoscopy and colonoscopy to assess for the presence of advanced colorectal neoplasia. And what I mean by advanced colorectal neoplasia is colorectal cancer as well as the colorectal cancer precursors, which we call advanced precancerous neoplasia. And there are 2 types, advanced adenomas and advanced sessile serrated lesions. And in their own way, over time, they can develop into colorectal cancer. So we also want to find out whether FIT can detect these precancerous lesions, which are more treatable before they turn into cancer. For the data analysis, we decided to determine the diagnostic accuracy of FIT for advanced colorectal neoplasia at 2 different thresholds, including 10 and 20 micrograms of hemoglobin per gram of feces. And we also did some multivariable logistic regression to determine the symptomatic, demographic, and clinical factors that were associated with advanced colorectal neoplasia at colonoscopy. So now I will present the results. This is still an ongoing study, so this is just the preliminary results. So what I've looked at so far are 100 participants that have completed FIT and colonoscopy between August 2020 and February this year. We excluded 5 due to poor bowel prep and incomplete colonoscopy. This left us with 95 participants. 23 had advanced colorectal neoplasia, 4 with colorectal cancer, 17 with advanced adenomas, and 2 with advanced sessile-serrated lesions. We also looked at the FIT results, which showed that 32 had a FIT over 10, and 21 had a FIT over 20. When looking at our multivariable logistic regression, we found that a positive FIT was the only factor associated with advanced colorectal neoplasia at colonoscopy. And this was true for both FIT thresholds. And we can see this because the p-value is less than 0.05. And now I'll show you a table showing the diagnostic accuracy of FIT for detecting advanced colorectal neoplasia. And what I've done is I've divided it up to colorectal cancer, precancerous neoplasia, and altogether as advanced colorectal neoplasia. And what we can see is that FIT is more sensitive at detecting colorectal cancer compared to precancerous neoplasia, and this is true for both FIT thresholds. We can see that FIT was able to detect all cases of colorectal cancer, and we can see this because the sensitivity is 100%. Now, when looking at the positivity rate, for a FIT threshold of 10, this was 33.68%, meaning that if we were to use FIT to triage a cohort, only about 32 would have needed a colonoscopy, and at the same time, we would have detected all cases of colorectal cancer, but not all cases of precancerous neoplasia. If we were to use a FIT threshold of 20, we would have the positivity rate is 22%, meaning that we could prevent about 80% of people from having colonoscopy, and at the same time detecting all cases of colorectal cancer, but even less cases of precancerous neoplasia. So in conclusion, out of our 95 iron-deficient patients, we had 4% that had colorectal cancer and 20% that had advanced precancerous lesions. We found that FIT is more sensitive at detecting colorectal cancer compared to advanced precancerous neoplasia. And our positive FIT is significantly associated with the presence of advanced colorectal neoplasia in patients presenting with iron deficiency. So overall, this shows that FIT may have a role in selecting for patients for prioritized colonoscopic evaluation in primary care. So looking into the future, we are continuing to recruit more research participants. I plan to look at the diagnostic accuracy of FIT for patients with iron deficiency anemia and compare that to those presenting with non-anemic iron deficiency. And we will do this after we obtain serology results from our participants. I also plan to analyze their upper endoscopy results and also look at the blood that we took from our participants. And this was to look for circulating tumor DNA biomarkers. And we want to see whether these DNA biomarkers can also help us determine which patients need a colonoscopy in conjunction with our 2-sample FIT. So thank you for everyone that's been involved in my research and for the audience here today. Questions?
Thanks, Jennifer. I think we're open for questions. Perhaps if I can start off while others are thinking. So you had 4 colon cancers in your group. Mm-hmm. Do you think that's enough to claim 100% sensitivity for your test?
No, I think that our cohort is still quite small, so I think we could be more confident if we had a larger sample size.
Yeah, and ideally you want a test that's 100% sensitive to colorectal pathology.
Yeah.
You probably don't care too much how sensitive it is because, how specific it is, because you can have some sort of negative colonoscopies, but you do want to pick up all your pathology. So you actually have missed some of the adenomas. Does that bother you?
Yeah. Yeah, I think that is concerning, but I would have to look further into that.
Okay. Any other questions? Okay. Thanks for a great presentation.
So we're tag teaming here. So we've got Gabby Shea next, who's talking about endometriosis diagnosis pathways in South Australia, a qualitative study. Thank you, Gabby.
So hi everyone, my name's Gabby and today I'll be presenting on the endometriosis diagnosis pathways in South Australia. So endometriosis is a major health issue affecting 1 in 9 Australian women. It is a common condition and yet frequently under-recognised and inadequately researched. The time taken from onset of symptoms to a confirmed diagnosis is an average of 6.4 years in Australia. Delayed diagnosis has been shown to lead to increasing rates of infertility, debilitating pain, social isolation, and a reduced quality of life. The total economic burden in Australia per year is approximately $6.5 billion, with majority of these costs being attributed to productivity loss. A national action plan in 2018 highlighted the need for increased awareness and education on the diagnosis process. There is a clear need to investigate the current pathways to endometriosis diagnosis in Australia and investigate potential reasons and impacts of potential delay. Our aim is therefore to explore the lived experiences of people with endometriosis in SA. This involves exploring themes such as the pathway taken to receiving a diagnosis, as well as impacts of any potential delayed diagnosis on mental health. To achieve these aims, we conducted a qualitative study using in-depth interviews of 50 people living in SA who were over the age of 18 and had a surgical diagnosis of endometriosis. We used a narrative approach to gather information of people's experiences of their diagnosis pathway. Narrative methods have been shown to be useful for people with endometriosis to articulate their experiences. The narratives of the 50 participants were then analysed thematically to identify codes related to our research question, which we then converted into themes. So this is a mind map of the several themes and sub-themes we found throughout our analysis of the interview data. As you can see, there is a number of complex and varied themes that came out of the transcripts. So therefore, to keep to time constraints today, I will be focusing on 3 areas: people's feelings and experiences with the symptom onset to surgical diagnosis time, the barriers to a diagnosis, and the mental health impact of a delayed diagnosis. People we interviewed felt that the time taken from symptom onset to receiving a diagnosis was far too long. They often experienced their frustration with the process and attributed many different reasons as to why this might have been the case. They would often present to health professionals with their symptoms for many years before endometriosis was discussed or investigated. A few participants were understanding of the fact that diagnosis takes a longer time due to the requirement for surgery, and that often symptoms start from the age of puberty. The majority, however, felt as if their life experiences might have been completely different if they had found out about their condition sooner. Most people we interviewed said that the first feeling that ran through their mind after they were told their diagnosis was relief and validation. These are some quotes about what the participants said they felt after they were asked how they felt when they heard the news. It is also important to note that for many, this initial feeling of relief was also followed by anxiety and sadness about knowing they were dealing with a lifelong chronic disease. There were 3 recurring themes that came up from the interviews, which participants believed were the main reasons that the diagnosis time was so delayed. These are the education and awareness of the condition, dismissal and normalisation of symptoms, and stigma and embarrassment about discussing symptoms. I'll now go further into each of these. One of the major barriers to getting a diagnosis discussed was inadequate education and awareness. Many felt that they did not receive the information and support required to be able to receive a diagnosis. Participants themselves felt uneducated in all areas of women's health and periods, and attributed this to a lack of information during school, GP consults, and often also in the family home. Many felt as though if they had been given the knowledge earlier on, that they may have been able to receive their diagnosis earlier. People that have had their diagnosis for a longer time commented that they felt as if in the last 5 years, research, advocacy and education has advanced significantly. This may potentially be due to an increase in funding from the National Action Plan in 2018. Nevertheless, there is still a long way to go to improve our education system to be more aware of symptoms that may warrant further investigation for endometriosis. Another major theme discussed by most participants was the normalisation and dismissal of their symptoms. This came from many directions, including friends, family, particularly mothers, health professionals, and eventually themselves. This would cause them to stop seeking healthcare or discussing with family or friends. We asked people where they thought this normalisation originated, and often they described a lack of education about the disease. As seen in the quotes, many people were told that their symptoms were normal and to just suck it up, take a Panadol, put a heat pack on. A prominent theme throughout analysis was the impact of female family members, particularly mums, on normalisation of symptoms. we discussed the idea of transgenerational normalisation, where their mothers were often told that their symptoms were normal, and so they passed this normalisation on to their children. It was often noted that participants felt that they were told so often that there was nothing wrong with them that they started to believe this themselves. This would cause them to feel apprehensive about seeking healthcare or discussing with family or friends. The final barrier I will discuss today is the stigma around periods and talking openly about them, as well as embarrassment to bring up their symptoms to friends, family, or health professionals. Many participants experienced their frustration with the stigma around discussing menstruation and how this hindered their ability to see whether they needed to seek medical advice. People often felt ashamed to discuss their symptoms with their GP, which again led to potential misdiagnoses or not understanding the full extent of their pain. Some discussed how they also felt a level of sexism. They commented that if this was a male issue, then it wouldn't be so underfunded and under-researched, as shown by the quote from participant 10 on the screen. Many of these people also reported early menarche, with getting periods as young as 9 or 10. This was an interesting added complexity where you feel very isolated from your peers when you're in a time where you just want to feel the same as everyone else. The lengthy diagnosis time had many impacts on participants, but in the interest of time, I want to focus on one common theme, which is mental health. They felt frustrated by not understanding what was going on with their own bodies, and that led to feelings of vulnerability, isolation, sadness, and anxiety. People attributed their poor mental health during the diagnosis process to many different factors, the main one being normalisation and dismissal. They struggled with their stigma they faced when discussing their symptoms and felt as if nobody believed the pain they were going through. As well as this, the pain from the undiagnosed endometriosis meant they felt socially isolated from their community without any known cause. They also found it really hard to engage in education and work when they felt so unwell for no known reason. This led to increased rates of days off school and work, which then creates a circle of social isolation. So in summary, the interviews conducted on South Australians with endometriosis provided a wealth of information and uncovered many themes to be discussed. The barriers that were most often discussed by the participants included lack of education and awareness about the disease, normalisation and dismissal of symptoms, and stigma and embarrassment about symptoms. Interesting findings from the research was the identification of people's feelings of relief and validation at the time of the diagnosis, and the discussion around transgenerational normalisation of symptoms. The main impact of delayed diagnosis we found is poor mental health, which interlinks with many other facets of life, such as financial status, social isolation, education, and work. Our recommendations from this study identify that more awareness and education about periods and endometriosis is required for both health practitioners, school children, and the general population. Thank you.
Oh, okay. Thanks, everyone. Any questions from the audience? I'll just ask you a quick question. I mean, qualitative studies like this often generate new ideas or new thoughts for research. Have you got any thoughts about if there was something you wanted to do in your future career that could be a way of either influencing or changing this experience for women?
Yeah, I think a big part of it is starting younger, so starting at schools and starting with the education programs in schools. I didn't have time to mention them, but there are a few that are going on at the moment which seem to be changing people's perception of women's health, which seems to be great.
Great. Now, we're going to have just to throw everyone off, we're just going to change order slightly because someone's running out. Lorraine, are you happy to go? Yeah. Yep. Is that I don't know, how will you sort out the slides? Your slides are next. So we're just going to have a slight change in the agenda. Lorraine Ho is going to go next, who is going to be talking about a qualitative study on the experiences of women undergoing symmetrisation surgery for developmental breast asymmetry. Sorry, I stole your thunder, David.
Hi everyone, my name is Lorraine. I'm a fourth year medical student and I'll try and find the slides. There we are. And today I'll be talking about my advanced studies research project, which is a qualitative study on the experiences of women undergoing symmetrization surgery for developmental breast asymmetry that I did in conjunction with the plastic surgery department. So developmental breast asymmetry, or DBA, is a term used to describe asymmetrical breasts. This can include severe variation in breast shape, size, symmetry, volume, location, nipple areola complex, as well as overall appearance. An example would be Poland syndrome, where there can be an absence or hyperplasia of the breast on one side. Understandably, this can result in significant psychosocial ramifications. There's also little qualitative data that looks into the subjective experiences of women with DBA. Therefore, our study aims to use a qualitative approach to explore the experiences of women who have grown up with DBA, the reconstruction journey, and the reconstruction outcomes. So we conducted 14 semi-structured interviews using a question guide with 14 participants who underwent reconstruction surgery with the Department of Plastic and Reconstructive Surgery at Flinders Medical Centre. All the interviews were recorded and manually transcribed, and the transcripts were then coded by myself and my research partner, Saima, who's also a fourth-year medical student. And we did coding through inductive thematic analysis. All the codes were then added to a code book, and they were revised continuously to create 5 major themes. So theme 1 explores the impact of growing up with DBA. So most women reported having poor body image and mental health, and here are some clips from our interviews to demonstrate that.
Like a woman, I didn't feel feminine, I didn't feel pretty, I felt like a freak, I didn't feel like I was normal.
And the second one.
There was some days I just really, not like, I wasn't suicidal, but I just was like, my life would be so much easier if I just, wasn't around, because it was just the pain it was causing on my shoulder every day, and like living through that, and it was just very miserable.
Many women also reported having difficulty entering intimate relationships and often hid their breasts during intimacy due to feelings of self-consciousness. DBA also affected many other aspects of their lives. They avoided activities like swimming or going to the beach in fear that people might notice their DBA. They were also unable to find clothes and bras that were suitable or comfortable, and often took great measures to actually hide their breasts by stuffing their bras or wearing baggy clothing. Several women experienced severe neck, shoulder, and back pain, and a few women actually reported being bullied for DBA as well. Overall, women described a strong feeling of shame and embarrassment due to their breasts, which permeated throughout all areas of their lives. The second theme talks about how women sought treatment and the obstacles they face. Many women feared seeking help as they were afraid of people looking at their breasts, and they feared that their feelings would be dismissed. Most women went to their GPs for help, and unfortunately some of them didn't get dismissed by their GPs. They were either told to lose weight or that one of their breasts would catch up, and for women who had physical symptoms, they were even labeled as drug seeking. Fortunately, other women had good experiences where their GPs acknowledged their concerns and made timely referrals. Theme 3 explores the information or lack of information that participants received about the surgical process. Most women recall being relatively well-informed about the surgical process, risk and benefits, and post-operative recovery. However, participants who experienced negative outcomes shared how their young age likely contributed to a suboptimal understanding of the information provided to them. In our study, most of our participants were approximately 18 years old when they had their surgery, and they described themselves as being really eager to undergo surgery to fix their DBA without truly comprehending the risk of surgery. They also felt that at such a young age, they didn't know what questions to ask at their appointments to develop a better understanding. All women also felt that it would have been useful to talk to other women with DBA who have undergone reconstruction surgery to get a better understanding of what the surgical process involves from a patient perspective. Theme 4 explores the medical and social support that participants received throughout their surgical journey. Women were very grateful for the emotional support provided by the surgical team in acknowledging their concerns and making them feel seen and heard. Women also reported needing a lot of support from friends and family, post-operatively with daily activities like showering, cooking, and cleaning, which they felt was crucial to their recovery. Other support that women mentioned they would have liked was long-term follow-up as an opportunity to reassess any post-surgical concerns such as implant replacement or changes to their breasts. And as mentioned in the previous slide, they would have liked to talk to other women with similar experiences. Theme 5 explores the varying outcomes from surgery. Most women had improved confidence, body image, and mental health. They were pleased with having symmetrical breasts and finally felt normal. They also could wear the clothes and do the things that they previously couldn't. And here's a clip from one of our participants.
Reconstruction has enabled me to live in full confidence within my own body.
However, some women didn't experience post-operative improvements. They were either dissatisfied with the surgical outcome or experienced post-operative complications that resulted in significant scarring or even removal of their implants. For these women, they still have ongoing psychosocial struggles, and here are more clips to elaborate on that.
Be like this for a year because I can't look at myself. I hate looking at myself now in the mirror.
Dated for 12 years. Yeah. I haven't been in a relationship since my last surgery. Yeah. So it's definitely impacted me in that way, hugely. Yeah, just confidence levels probably dropped.
And in terms of what they would do differently, some women wish they had explored other reconstruction options or even gone for a larger implant. And some women wish they had less scarring as a result of the surgery. However, for these women, they were still pleased with the overall outcome and the improvements that they had. Oh, sorry. Women who also underwent surgery at a later age also wish that they had undergone the surgery at an earlier. So moving on to discussion. So our study reiterated the significant impact that DBA has on women's psychosocial well-being, namely in the form of poor body image, mental health, and overall quality of life. The negative GP experiences that some of our participants had highlighted the lack of awareness about DBA within the medical sector and the need to raise awareness. This way, women might have their concerns taken more seriously and might be referred in a more timely manner, all of which would improve the overall treatment-seeking experience. Moreover, considering that all women have a degree of natural breast asymmetry, raising awareness within the community might also normalize breast asymmetry to a certain extent and make women feel less self-conscious and less like freaks. However, for women with more severe breast asymmetry, raising awareness might also inform them about reconstruction options that are out there. And like many other studies surrounding breast asymmetry, our study also demonstrated that reconstruction surgery improves psychosocial well-being. However, it's important to note that this isn't always the case. Some patients will experience post-operative complications that result in poor outcomes, and some patients will have unmet expectations. Thus, this highlights the need to thoroughly educate and inform patients about the risk of surgeries as well as the limitations. Building on that, it's also key to consider the fact that most participants undergoing reconstruction surgery are likely young and will need more support and information to understand the significance of reconstruction surgery. Such support could involve talking to other women with similar experiences. So in conclusion, DBA has debilitating effects on women's psychosocial well-being. There's a need to raise awareness and a need to raise awareness about DBA and a need to be mindful that surgery isn't always a guaranteed solution. Information and education around surgery is also an important consideration for women undergoing reconstruction surgery in the future. And that brings me to the end of my presentation. And before I end, I'd like to thank Tamara, Philippa, Andrea, and Dr. Dean for the unwavering support they've provided throughout this research project, as well as the participants that have helped make this research project possible. Thank you, everyone, for your time and attention. I hope it's been informative about DBA.
Thanks, Lorraine. I'll ask one question. Sure. So you've shown, I think you've shown a sort of a mixed bag of results, really. Yep. You know, some people are happy, some people not so happy. So what are the next steps to try and sort of work out what to do with people with this problem?
Well, I think the most important thing that we've discussed with my supervisors is that raising awareness is one key element to trying to normalize and also normalize breast asymmetry to a certain extent. But I think the bigger factor is also having more education and support leading up to reconstruction surgery, which may educate patients on the risk and limitations of surgery, and thus that may help to reduce the amount of patients that have unmet expectations and adverse and dissatisfaction with adverse outcomes, if that makes sense.
Okay.
Yeah. Thank you.
So again, continuing out of sync, Minju Kwan. Minju is our next speaker. She's talking about understanding men's engagement and disengagement when seeking support for mental health. Look forward to your talk.
So I just need to skip through slides. Yeah, okay. Oh, good, okay. Hi, I'm Minju. I have another qualitative research, but yeah, I looked into men's experience with mental health services and what can impact their engagement. And just before I start, I'd like to flag that this does not apply to all men, obviously, and it's important to provide personalised care for each patient. So we all know men in our life who hates going to doctors and will never ask for help. And for some of you, it might be yourself. But in general, men are less likely to use healthcare services compared to women. And when they do, they tend to focus on physical problems like pain, discomfort, and rarely comes in with mental health issues or concerns. There is general reluctance to seek help, even at the point of crisis. And we know that men are more likely to commit suicide compared to women. Some data suggesting it could be as high as 4 times higher than women. So what we currently understand about this tendency in men, so they can see health as a bothersome, and there are values within traditional masculinity, such as men has to be strong, independent, invulnerable, stoic, which all goes against that act of help seeking. And there are social cultural expectations on these men to be along with those values, and there are social stigmas. And men tend to have poor mental health literacy, and by that I mean they struggle to identify and describe their emotions, really hard to pick up those early signs of mental health deteriorations, and may only realise there's something wrong at the point of crisis. So existing researchers recommend using community-based approaches to help men get mental health support. So essentially men gets to work with other men, and that helps them to see other people going through the same thing and reduce that stigma. So example could be like men's shared services. And also there's a need for a gender-sensitive approach where we focus on active problem solving, encouraging active engagement from men, and clear goal settings. So, and what my research adds is we add that consumer voice to the already existing data, which has mainly been quantitative. And we also we look beyond the initial engagement and focusing on what can we do to bring back men who has already engaged with service but was let down, and what can we do to bring back these men, because essentially they've overcome those initial barriers to make the first contact with the services. In terms of methods, so there was a national survey done by Lived Experience Australia, and we had 73 male consumer responses, and all these questions required a long extended response from the patients, from the participants, and we've done qualitative data analysis to form themes. So results, there are 2 main themes. So firstly we'll look at why people disengage, and secondly we'll look at what we can do to bring these men back to services. So first thing was autonomy. So participants were often let down by clinicians who failed to respect autonomy of the consumers. So they really wanted to be involved in that decision making in their care. However, they were not given choices and did not have their perspectives integrated into the care. And some people almost felt like they were forced into particular treatments that their clinician wanted, but they didn't want. And on the other hand, the such strong sense of autonomy led to some participants self-diagnosing, self-evaluating their mental health status, and disengaging with the services prematurely, not knowing it was actually the services that helped them to feel better. And next thing is professionalism. So lack of professionalism and clinical incompetency were something that disappointed people. So this included when the clinician was not being able to offer a variety of services that they wanted, and when they show uncertainty in their knowledge and wasn't transparent with their clinical limitations. Also, there are actually many cases of people resigning, moving, and retiring without letting the clients know. So a lot of these clients were essentially fell through the gaps. And also some people showed emotional exhaustion, which disappointed the participants. So next thing is authenticity, and almost all participants expressed that they felt like their healthcare providers were not genuinely interested in them as a person, and there was no genuine empathy, and there was lack of listening and lack of effort for rapport building. And obviously there are systemic barriers. The big thing was poor coordination between the health services. So there was a lack of consistency, and consumers were responsible for telling their own stories multiple times to different people, having to be solely in charge of all the information which could be very tiring. And when they presented to health services at the point of crisis, there was no appropriate follow-up, more like active follow-up, and fell through the gap. And there's an issue of accessibility where the cost can be a problem, number of visits covered by mental health care plan, and long wait times. So second theme is what can we do to help these men who've been let down by the system re-engage? So something the participants wanted was an opportunity to provide an honest feedback to health professionals, and they wanted a safe space to discuss their experience and the chance to mend that therapeutic relationship. And one participant suggested having like an online third-party feedback thing would be really beneficial for them, and then they can provide that honest feedback. And secondly, community and peer workers. There were many positive reports about peer workers and community-based services. So peer workers are mental health care workers who have had personal experience of mental health struggles, and the participants perceived the support from someone with a true lived experience as more authentic and they felt more understood and thought they were better empathy. And there was a desire for lived experience support groups, and they said these support groups could help them focus on the human and social aspect of things and help them feel connected and find more meaning in their care. And lastly, ease of re-entry. So they really there was a strong need for that one consistent main point of contact, and they wanted active follow-up from the services even after they disengaged, either by like a phone call or like a survey or like a feedback system that helped them to feel like they can come back whenever if they need that service again. And the general systematic improvement of like for example, longer validity of mental health care plans and having more visits covered to not so it deburdens the cost. So what can be done from the healthcare provider perspective? So active communication is very important, and we actually recommend setting a review points at the earlier part of the therapeutic relationships to say, okay, every 3 to 4 appointments, we're going to talk about what's going well, what's not going well, what things you want in your care, and just ongoing reminder to the patient that they can always provide feedback at any time, and keeping everyone in the loop. So active follow-ups and those feedback systems as we discussed, and consumer education where we optimize the mental health literacy so these men can actually come back to services before they reach the point of crisis. And finally, informing the patients about the community-based and peer worker support, so let them know that option does exist and essentially refer as appropriate. That's it. Thank you. Any questions?
Thanks, Minju. I've got a quick question.
Yep.
So it was 70 participants from a larger survey,
Yeah,
is that right?
Certainly, yeah.
So how did you choose those 70, and is there any...
Oh no, sorry, it was 535 of total responders, and among them 73 were male. So this was all male, all male responses from that pool.
So in that survey, was there any chance that those 70 men who actually were willing enough to respond to actually write a lot on a written survey? That's quite a unique group of people. Do you think that might have influenced the themes that you got? Because, you know, speaking as a man, if I get a survey, I don't answer them.
Yeah, certainly. So that's why, so essentially a lot of our data, so that's why I did a lot of comparing with the existing data, and essentially we were adding that qualitative data, already confirming what's already out there. And then we find, and I guess the new thing that we looked in our research was how to bring people back, which is not something everyone looks at too, yeah.
Is that it, do you think? There's some. Doesn't look like a Nick. Well, we did have one other speaker, but I believe he's not here. Is that correct? Nicholas? Is that Nicholas? Oh, hi. You need to run on down. Come on down. For those of you who are old enough to remember that, that's probably clearly only me. It's a lost pop culture reference. Sorry.
Don't be sorry. I'm sorry.
No, you're sorry. You're running a little bit late, but that's okay.
Thanks very much.
We have, with a grand entrance, we have Nicholas Morfidis. Morfidis. That's right. Morfidis, who's talking about paediatric weight estimation formulas in Australian Paediatric Emergency Department, a retrospective cross-sectional study. So.
Thank you. Oh, there we go. Great. It's easy for see. It's not reading it. It's in my email though. There we go. Thank you. I was actually just stalling to catch my breath. So, hi everybody, my name is Nick. Thank you for waiting, and thank you for listening as well. I'll be presenting my advanced studies research titled Pediatric Weight Estimation Formulas in an Australian Pediatric Emergency Department, a retrospective cross-sectional study. But big thanks to Dr. Carl Sprick and James Pierce, my supervisors, and also thanks to Flinders for all the support they've given. So let's look at today's goal. Well, the term using retrospective data to validate age-only pediatric weight algorithms used in emergencies, that's quite a mouthful. So let's just reorientate and let's just think, what is the best pediatric weight algorithm we can use in our hospital? The background being that knowing the weight of a child is critical for drug dose calculations, equipment sizing, and other techniques for patient care. In some cases, though, the weight of a child's unknown and can't be obtained by weighing them, either due to illness severity or they can't ambulate onto the scales or we don't have scales. There's a variety of different algorithms which attempt to estimate pediatric weight based on their age, and many of these are used in different health institutions across Australia, but what's the best one that we can use in Flinders? And so resus.org has a few recommendations for estimating weight. It actually says that, well, we should just use their actual weight rather than estimate. And then if we have to estimate, we should use maybe a body length tape, like a Brown's-Low tape, or an emergency drug chart. But if you can't use those, they have age-based weight algorithms. And so even though there's all these other things that come before using an age-based weight algorithm, the reason we want the best one is that it'd be a poor example of evidence-based medicine to not use the best if we can. And so our research goals was to find which pediatric age-only weight formula best fits the target populations of Flinders, to create a new one that performs even better than those we find in the literature, and also to determine if there's a significant difference between patients who self-present versus patients who present via emergency services. So it's a cross-sectional observational study that used patient data collected from FNC ED between August and October 2021. The first thing we did was a literature search to find existing algorithms, and then we used the patient age and weight from our cohort to calculate the performance of those existing algorithms. So bias, accuracy, and precision using different statistical formulae. We then created a new algorithm that surpassed the performance of all those existing ones. So these are just some of the equations we use for calculating bias, precision, and the accuracy. And these are some of the algorithms we found across Australian services. So we have Queensland Ambulance Service, Ambulance Victoria, and a few other ones there, APLS, which is really popular. And you'll notice that different formula have a different level of simplicity as well. So some are really easy to remember and others aren't. So which one do we use? We will find out. The results that we found, so we had 3,405 cases of patients aged between 0 to 15, 1,854 males, 1,549 females, and 2,867 were self-presenting versus 538 by ambulance services. This is a scatter plot of the patient age versus their actual weight, and these different lines here are some examples of some algorithms to estimate weight based on age. So you can see some overperform and some underperform based on different age groups. Our data was very positively skewed, so there was a lot more presentations in earlier ages than there were in later ages. And because of this, in order to determine if there was a significant difference in weight between the mode of presentation or gender, we had to use an independent samples Mann-Whitney U test. We found no significant difference in weight across genders or modes of arrival, which means you can use the same algorithm regardless of gender and regardless of whether they self-presented or were picked up by emergency services. This is the first algorithm we invented, so the Flinders formula. It's comprised of 4 different formula for different age groups. And we also made another one called the Flinders Formula Simplified, which is a lot easier to remember, but it may sacrifice a little bit of performance. So what we did was we calculated the bias and precision and accuracy across all the different age groups, but there's a lot of numbers here. So let's just look at the totals. So this first column is the bias, measured in mean percentage error. The second column is the precision, measured in mean absolute percentage error. And the third and fourth columns are the amount of estimations that were within 10% of the actual weight, which is P10, or within 20% of the actual weight, which is P20. And the Flinders formula measured the best in every metric. The Flinders formula simplified measured the second best in every metric except for bias. It was the third best in that. And so what we found was the Flinders formula was the least biased, the most precise, the most accurate, and was comprised of 4 formula. It also estimates between the ages of 0 and 15 years old, whereas some other formulas only estimate to 10 years old, such as the APLS. And the Flinders formula simplified is really comparable, has a low bias, a high precision, a high accuracy, and it's easy to remember. It's only comprised of 2 formula, and also estimates between the age groups of 0 and 15 years. And so now we have validated 2 age-only algorithms for the estimation of pediatric weight, which perform better when compared to other algorithms in the literature for Flinders Medical Center. But the true impact of utilizing an improved algorithm on actual patient outcomes still remains unknown. A future study investigating that would be valuable. So thank you very much.
Thank you, Nick. Any questions? I've got a quick question.
Sure.
So, I mean, usually when you're using these estimation formulas, the risk is whether the formula systematically under or overdoses. How do these formula perform? I mean, obviously the Flinders formula is clearly fantastic, but, it's better than the others. But do any of the others that are in common use tend to will systematically underdose or overdose?
Yeah, so if we look at the mean percentage error here, the total, the graph on the far right, shows the bias.
Yeah.
So a negative means that in general, it underestimates, and a positive means it overestimates. So we can see, for instance, that the best guess formula, which is from a textbook, tends to underestimate by about 10%,
right,
whereas Queensland Ambulance Services tends to overestimate by 4% on average. And it's almost better to, well, it's really up to the service, but if you were to underestimate the weight, then for safety purposes, you're less likely to give too much of a dose and overdose.
Yeah. I mean, I don't know how. I mean, I suppose that's the other question is, how much does 10% difference in a drug dose make out of, it might make a difference in a very one dose versus another. Do you have any sense for?
That's right.
Do we have evidence that the other formulas have been causing harm, I suppose?
No, so that's where the next step is really just what's the true impact on actual outcomes based on changing a formula to be more accurate. And, I think probably if you were to ask a lot of emergency physicians, they would say on average it doesn't make that much of a difference, but maybe there are some cases where it would.
One of the risks of your more complex formula is that people might, in an emergency, might thinking, what the hell's that dose?
That's right, which is why having 2, I think, one more complex, one less, and I think it'd be up to the physician in that case to determine what they're capable of.
Good. Oh, there is a question. Nikki.
I just wanted to ask, what was the level of variability in the groups? I mean, we've got a 15-year-old trial with Willie that weighs 155 kilos at the moment. And so, you're always going to get outliers. So
that's right.
With this algorithm, you would have some sort of caveats.
Yeah, and so what we did was the way that we removed outliers was by 1.5 times the interquartile range. And so really these algorithms can only be used in children that aren't obviously over or underweight, because that's always a risk.
Oh, up there. Yes, sorry.
Yeah, so the APLS, so if we look at our simplified version, really the only difference is we still only have one formula for the ages of 1 to 15 years old. Where things just get a little bit more precise is if you want an actual formula for under 1 year old, because most formulae for under 1 year old would just give a set value. So for instance, for 24 hours, the Ambulance Victoria sets a weight at 3.5 kilos. At 3 months or 6 months, they have 6 kilos and 8 kilos. The only difference we have really is if you wanted to estimate under 1-year-olds more precisely, we have a formula that takes into account every month as opposed to otherwise. But I guess it's up to a physician to determine how much precision and accuracy versus how much they'd like to remember. And we'd like to hope that maybe they could remember just one more formula, but I know that we're already cramming so many in there. So, and if things get too complex, apps can always be used. Something on the phone like MedCalc can incorporate something like this.
Oh, we've got another question. Gosh, this is hot property.
Yeah, so the purpose of this was to find a formula that is related specifically to really this geographical location in this point in time. So, because if we were to look at, the average pediatric weight in a different state, or even 10 years from now, it could be very different. We didn't measure our formula with weights of other geographic locations because we probably wouldn't have much utility in that. But yeah, things like, for instance, the rising obesity epidemic means that not only is time a factor, but also our cultural practices tend to mean that children grow in certain ways, and that's related to our geographic location as well.
Okay, it is 3:15, which means we're over time, and there'll be people dying of caffeine withdrawal at this particular juncture. So, Professor Burston, you're Oh, okay, thank you. I just wanted to thank the speakers, and really it is testament to the future of my and our David's profession that we're going to have some great researchers out of that lot, because I think there's been some fantastic work done, and obviously we need to thank supervisors and the participants of the research. And I was going to let you go to afternoon tea, but I don't think I can.
Thanks, Craig, and thanks, David, very much. Great presentations. Look, just to remind you that there are some posters on at afternoon tea, so grab a drink, grab something to eat, and please support the posters as well. That would be great. People put a lot of work into them, and I think they've been fantastic sessions so far as well, so please help support those, and we'll see you back shortly.
I'll take that off as well because I've got Slido.
free paper session. I'm George, and with me I have Dr. Catherine Martinello.
Hello, everyone. We're going to be hosting this session for you today, just sharing. The most important thing to say is that there are prizes for this session, so please do vote while you're here. You can use this code to get onto Slido and to vote for who you think did the best presentation. And actually, the prizes are quite generous, so it's certainly worth voting for your colleagues.
So, first up, we have Dr. Victoria Tang, who will be presenting her paper entitled Childhood Myopia is Significantly Associated with Circadian Rhythm Disruption and Poor Sleep. Dr. Victoria Tang.
Sorry, just got to fix up the PowerPoint. Hi, everyone. This is Sam. Sam is a young boy from suburban Adelaide. He's 7 years old, and his favourite thing to do is read books at night time, under the covers, way past his bedtime. And lots of his friends do the same thing. And by the time Sam reaches high school, he wears glasses. He does quite well, and lots of his friends wear glasses too. It's no big deal, it's just short-sightedness, he says. And by the time Sam is married with kids, he starts to pay a little bit more attention to his health, and he books in for an eye test, where they tell him that his eyeball is elongated, which is not uncommon for someone with myopia. But his optic nerves, the cables that run from his brain to his retina, insert into his eyeball at a funny angle. And his retina almost appears stretched thin in parts, and he's got patches of atrophy in his eye that he otherwise wouldn't have known about. So Sam, on his 40th birthday, goes for a walk one day, and he starts to get flashing lights in his eyes. He thinks back to his last eye test as he starts to lose vision out of the corner of his eye. Because of his myopia, Sam has had a retinal tear. It's now progressed to a retinal detachment, and he has permanent vision loss in that eye forever. Could we have done anything about that? It's just short-sightedness after all. Is it even related? Well, myopia is the technical term for short-sightedness, but it's not that simple. It's a disease, and it's a big problem at that. And by 2050, more than half of the population is projected to have myopia. And of those, a subset will go on to have high degrees of myopia and will suffer terrible complications like we've just seen. And that's up to 10% of the global population. And as we've seen through Sam, myopia causes physical changes in the eye, and you're more likely to get other eye diseases if you are short-sighted. So is there some way we could go back in time and change things for young Sam so that he never had to go through this in the first place? And to do that, we actually need to understand what myopia is and how it happens, and what's common to myopic people compared to those with normal vision. And what do we know so far? Well, people with myopia tend to excel academically. They tend to have, on average, higher intelligence. They live in urbanised areas and have increased near-work exposure, that is things like using your phone and laptop, and have reduced outdoor time and potentially sleep later than their non-myopic peers. And all of this points to a picture of an urbanised lifestyle to which myopia is more commonly associated. And our research aimed to build on this to see whether there's a biological mechanism that underpins all of this. Which brings me to the circadian rhythm. The circadian rhythm refers to our body's response to the natural 24-hour cycle that underpins the basic functions of our body and responses to light. and that refers to the light-dark cycle, as well as our sleep, which naturally occurs at night time in the dark. And one of the key players is melatonin, which is a sleep hormone. And we know from previous research in animals that there's a good link between the young developing eye and the circadian rhythm. We found that chicks without a light-dark cycle develop refractive error. And chicks that were reared indoors compared with those that were reared outdoors tended to have down-regulation of clock genes, which are these genetic sequences that control the eye's response to the circadian rhythm. And in knockout mice without these clock genes, they actually developed myopic changes in their eyes. So specifically, our research aimed to look at whether there is circadian rhythm dysfunction in humans, and in particular, myopic children. And to do that, we really wanted to map out the circadian rhythm. And we did that through looking at objective markers, so urinary melatonin output, the dim light melatonin onset through measuring saliva, and what that is it's the timing of melatonin secretion as we approach nighttime or sleep time. And we also looked at these kids' usual light exposure and activity through a process known as actigraphy. We also looked at subjective reports of how they felt their sleep quality, quantity, and near work was through the use of validated questionnaires, as I've listed there. With reference to the methodology, the sample size was 45. We had 26 myopic children and 19 non-myopic children who all underwent a comprehensive eye examination at the Health to Go clinic. And after that, we subjected them to a 7-day period where we asked them to record their usual sleep-wake cycles through a diary. We also had them wear a wrist-worn device which measured their light exposure and their usual activity. And we also asked them to complete the questionnaires, as I mentioned. And once all of that was complete, we invited all of these children to the Flinders Health and Medical Research Institute sleep lab, where we collected melatonin through the urine, as well as salivary melatonin every 30 minutes to capture that dim light melatonin onset I was talking about. And that was a temperature and light controlled environment. And what we found from all of this data that we collected was really interesting. Firstly, myopic children have significantly reduced average daily light exposure. So when we looked at that data that we collected on the wrist-worn devices, we found that across the entire week, myopic children had reduced light exposure compared to their non-myopic peers. And when you average that out across a 24-hour period, it's significantly reduced in myopic children. And this is something that's well supported in the literature already. But what we found was interesting with the melatonin data is that myopes have significantly reduced melatonin output and significantly delayed dim light melatonin onset. So in the overnight study, we found that children with myopia produced less melatonin than their non-myopic peers, and the timing of the first secretion of melatonin was delayed by about 1 hour and 20 minutes. So how does that actually play into the circadian rhythm? Well, if the circadian rhythm is like a conductor which orchestrates when your body feels awake and when it feels asleep, in myopic children, we found that this conductor operates on a slightly delayed schedule by roughly 1 hour and 20 minutes. So it's no surprise that using the actigraphy data to collect data about their sleep, and this is in that 7-day period, we found that myopic children are significantly phase delayed compared to their non-myopic peers, not limited to their bedtime and their wake-up time. Using the subjective data that we collected through those validated questionnaires, it's again no surprise that myopic children tended to self-identify as relatively more evening-type chronotype. And interestingly, when we used the sleep condition indicator questionnaire, we found that myopic children tended to report poorer sleep quality and insomnia symptoms. But it's not just limited to those significant findings. We actually found an association between the degree of myopia and the extent of the circadian rhythm dysfunction. So whether you look at myopia through actually measuring the length of the eyeball or the axial length, or the prescription, which is the more negative your prescription is, the more myopic you are. When we look at those two parameters, we find that the urinary melatonin is more reduced the more myopic you are. and your dim light melatonin onset is more delayed the more myopic you are. So, if sleep and light are so closely linked with short-sightedness, what would have happened if Sam swapped his nighttime reading habit for a morning walk? Would he still need to wear glasses? And could we, with something so simple, a habit change in his early life, have prevented the consequences of his myopia further down the track? Our research links myopia in children with poor sleep and circadian rhythm dysfunction. And we find that the worse the myopia is, the more disrupted the circadian rhythm seems to be. Now, as a research group, our priority is to follow these children 1 year in the future as their myopia progresses to see whether these circadian rhythm dysfunctions still exist. But really, this begs the question, can fixing a disrupted circadian rhythm result in better vision outcomes and change refractive outcomes for the better? Thank you very much. Also have some acknowledgements there.
That was extremely interesting. Do we have any questions from the audience? Dr. Dean.
Reading's good. I mean, how do you counterbalance that with your paediatric colleagues? Because obviously reading in childhood is something that we usually try to fight to preserve.
And I agree with you. And we find that, myopia tends to be a problem of more developed nations. And the dilemma is working out what's the best intervention for this. So I don't think we should stop reading, but it's whether we can work out the best time to read, whether we can find other interventions, particularly with this circadian rhythm, with the findings that we've found. Can we use some other sort of therapy or simple measures? So increasing outdoor time in conjunction with, managing the near work that we want to support in children to be able to optimise the refractive outcomes. So I think it's all a balance.
You have another question from Nick? Nick, just a second for the sake of the audience online.
Yeah, it seems like reading is kind of the variable that's being considered, but it seems like, at least nowadays with technology and things like that, close phone usage, would that have the same kind of effect or a greater effect than reading under the bed sheets?
Yeah, I think I use that example just to demonstrate, that dim light and reduced light exposure and kind of tying it all in. But yes, I agree. Smartphone usage is a big one, and I think, kids nowadays are using a lot more up close. It's probably, and when we did our near work questionnaire to actually look at the near work that these kids in our study actually did, we found that they did use things like smartphones at night time. So it is a big problem. I think it's all kind of to do with how we can balance it again with what near work is unavoidable and the treatments that we can, or the interventions that we can impose to kind of work with what we need to work with, yeah. But I agree, it's a growing problem, as we can tell from it kind of shocked me that by 2050, almost half of the population will have short-sightedness. So, yeah.
Thank you very much, Victoria. And we will move. Let's have a round of applause. That was a nice study. Let us move to the next speaker. It's Dr. Mark Hassel, who's a senior registrar in ophthalmology, and who will be presenting his study, Polygenic Risk Predicts the Success... Oh, okay. Wasn't going to hurt me. Polygenic Risk Predicts the Success of First-Line Treatment for Glaucoma. Mark.
Polygenic risk predicts the success of treatments in patients who have just been diagnosed with glaucoma, and that's an interesting finding and a clinically relevant one, and let me explain why. I'll start by describing glaucoma and the treatments that we use to lower pressure to prevent blindness. I'll introduce to you the basic concepts of a polygenic risk score, which is a novel application of genetics to help in the clinic, and then we'll talk about the specific prospective study of treatment, in which I'll show you that higher polygenic risk patients require more treatment, The polygenic risk predicts both the magnitude and the persistence of the treatment effect, and that SLT laser may be more effective than drops as a treatment for patients at high genetic risk of this disease. And we'll talk about why that's significant. So next year when FIMRI opens and we all go to the opening, most of us will experience the view like this, and a patient with advanced glaucoma will have tunnel vision. Their peripheral vision will have been taken by high pressure in their eye, and they will have a central tunnel of vision left to them that without treatment would progress to complete vision loss. It's a significant public health burden. It's the leading cause of irreversible blindness in the world. It costs the Australian economy $3.2 billion in the last 3 years, and it's all about pressure. Pressure is what drives the vision loss. Genetically determined factors that modulate the physiology of fluid drainage at the trabecular meshwork in the front of the eye can result in dysfunction in later age, causing pressure to crush or squash the optic nerve at the back of the eye, resulting in that characteristic pattern of peripheral field loss. And the important thing to remember is that intraocular pressure is the only modifiable risk factor to prevent vision loss in this significantly common disease. And so the way in which we reduce intraocular pressure is if a patient presents with a new diagnosis of glaucoma, they are offered either drops, typically Xalatan, or laser, selective laser trabeculoplasty, or SLT laser for short. And this diagram gives you an indication that that laser is delivered painlessly at the front of the eye to the trabecular meshwork. And those two are supported by landmark studies in the field of ophthalmology published in Lancet and the British Journal of Ophthalmology, and they are offered equally to patients. Both of them are considered equivalent treatments with no specific way of identifying patients who may benefit from one of these treatments in particular. Advanced disease requires surgery, but here we're dealing with early disease. Let's talk about how the polygenic risk score is created and then later how it can be applied to help treatment. So glaucoma is highly heritable, one of the most heritable diseases. It runs strongly in families, but it's not a simple genetic trait like a Mendelian trait such as autosomal recessive cystic fibrosis. It's a complex trait like height with multiple genes contributing small components of the total final outcome. So you can develop a numerical representation of this genome-wide risk for a particular condition like glaucoma by measuring, and this is something that we have done here at Flinders, that we have published on, and that is being turned now into an accredited test that is available in our clinic here at Flinders and around Australia. But you measure features of glaucoma in cases and controls, you measure the genome and look for variations, and then you give a weighting to certain genetic variations, of which there are hundreds, that contribute to the chance of glaucoma. And if you plot all these genetic variations across the genome, this Manhattan plot shows the 22 autosomes and the 2,763 uncorrelated SNPs that contribute to a person's polygenic risk score of glaucoma. So what does that mean? It means if you come to level 2 to see us in the glaucoma clinic tomorrow afternoon and you spit in a cup and we send it away for testing, a month later we will know which of those particular gene loci or those variants you contain, and then we can apply a numerical weighting to each of those variants to calculate a score. Now that number in itself is not so relevant, but when you plot it on a bell curve and you relate it to a normal population, you can say that an individual is in the top 2% of the risk of developing glaucoma and losing vision. And when we do these analysis in these large cohorts of glaucoma that I'm about to show you, we would present or compare the bottom 80% to the highest 20% of glaucoma risk. That's quite a conventional way that we've published on already to understand how that high end of the tail of risk affects disease. And as I mentioned before, you can now order this test in Australia, and we've just been feeding back some results to patients in the last couple of months. So applying it specifically to treatment in patients in a prospective clinical registry, we're looking at patients who are suspected of having glaucoma but do not yet have the diagnosis, followed longitudinally, and when the clinician identifies the onset of glaucoma or an unacceptably high pressure, initiating treatment at their discretion for the first line of drops or laser, SLT laser, and the clinician being blinded to the glaucoma polygenic risk score, so not actually knowing about this important covariate. And looking then at the reduction in IOP following treatment and relating that reduction in intraocular pressure to two clinically relevant outcomes, which are published in the landmark studies that I mentioned before that underpin all of these two treatments being offered, which is, can you reduce the pressure by 4 points or can you reduce it from baseline by 20%? So when we look at the numbers of patients that were treated in our group, and we look at the bottom 80% of genetic risk in that group versus the top 20%, we see that 215 treatment-naive eyes across 191 patients were treated, and that patients in the top 20% of genetic risk were more likely to require treatment during that period. Drops were used more often than SLT, and that's an important point that I'll return to at the end, based on our results. And we see that the polygenic risk score between the different types of treatment was no different between one group and the other. And here we see that the chances or the odds ratio of achieving a 4mm reduction or a 20% reduction from baseline in IOP is much greater if you're in the top 20% of genetic risk. Your odds ratio is 2.8, a significant result that, if we look into further with a multivariate model, tells us some interesting things about how polygenic risk influences treatment response. So for a patient in the top 20% of the population risk, a multivariate model shows that baseline intraocular pressure influences the magnitude and the success of the therapy. That's a known fact, but it's corroborated again in our data. We also show that patients in the top 20% of risk, this has a significant effect on the success of their treatment based on their genetic status alone, and that occurs with increasing magnitude of effect the higher the patient's pressure is. And we also identified an interesting signal in this initial prospective cohort that showed that patients with SLT laser may, this is something for further study, may receive a greater benefit compared to drops based on their genetic risk. Another interesting finding that is relevant clinically in this prospective cohort is that if you follow those patients longitudinally after their initial therapy, the patients in the highest risk of glaucoma, the top 20% of the PRS, are more likely to have sustained treatment effect, which speaks at length, and perhaps is beyond the scope of this talk, to the mechanism by which treatments act in this disease and the spectrum of phenotype. So the conclusions are that patients with a higher polygenic risk score, which is now a readily available test, receive more treatment than their lower polygenic risk peers. Patients with a higher PRS achieve a greater reduction in intraocular pressure, regardless of what their starting pressure is, and that this is a significant finding. And there is a signal in the data that SLT laser may be superior than drops in high genetic risk glaucoma patients, which is a topic for further study for us. And the reason why these are significant is that never before has it been reported that these two landmark studies of glaucoma had any understanding of the role of genetic risk in the outcomes of those two studies that we apply day to day in clinic. This is the first evidence in any disease that polygenic risk affects the magnitude of treatment outcomes in these patients, and it provides us a pathway to further explore whether SLT laser is a more appropriate and customised, personalised treatment that might be offered based on genetic testing results. And to answer that question, we're both establishing a randomised clinical trial based on high polygenic risk randomisation, and we are also fractionating that polygenic risk score, which is a big number, into two components. Components that are related to genes that influence pressure in the trabecular meshwork, and genes that control the nerve. And by looking specifically at the subset that regulates trabecular meshwork pressure, we hope to further identify those patients that would benefit from SLT laser to their trabecular meshwork. Projects like this with hundreds of patients across multiple sites require a lot of collaborators, and here are all of those people who have contributed to this work. Happy to take any questions.
Another very interesting presentation from the Department of Ophthalmology. Do we have any questions from the audience? Okay.
Sorry, I know I came partway through your talk and apologise for doing that. I'm just interested, so the polygenetic testing, is that expensive? Like, is it routine practice?
Well, it's just been developed and it has accreditation in Australia as a world first as of 2 months ago. So no, it's not routine, it's world leading. It's $305 if you want to do the test, but at the moment we're building evidence to say that it is such a valuable public health intervention that it would be worth being subsidised by a Medicare benefit scheme item number, but that takes prospective trials, which we're establishing now, but will take time. But yes, we have tested some people, and we've tested some people in the lab as well out of interest, and I think that test will continue to be used more.
If you don't have any other questions in the audience, I have a couple of questions. One relates to treatment-naive eye. Now, was the other eye treated? Because if so, I mean, from memories of ophthalmology, they say there's a sympathetic association between the two eyes, and was the treatment of the other eye affecting the results you saw in the eye that was treated?
So the only patients included in that analysis are patients who have had no previous drops or laser, and typically if patients are going to start treatment on both eyes, they will typically start the treatment at the first presentation. So any patient in this who's had more than one eye treated, they started both eyes on the same day.
Okay. And do you treat glaucoma with just one pharmacological agent, or are there more than one? Because when you say drops,
Yeah.
why are we seeing a difference?
There's a normal ladder of escalation that starts with either laser or first-line drops, typically a prostaglandin analogue, but there are 4 pharmacological topical agents that you would sort of work through the ladder as they fail to respond to therapy, and then proceed to surgery if the disease became advanced
And
enough.
so in this study, were all patients who were analyzed treated with one type of agent, or did they use more than one agent?
More than 4 out of 5 had the same agent, which is the conventional first-line prostaglandin analogue. Okay. Yeah, if they had the drops.
Well, if there are no other questions, I'd like to thank Mark for his wonderful presentation, and we will move a round of applause. And we will move to the next presenter, Mr. Greg Roberts, a familiar face on the wards in Flinders Medical Centre. He's a senior pharmacist, and Greg will be speaking to us about mild glycemia exposure in the critical care setting and hospital mortality, the need to challenge conventional thinking. Over to you, Greg.
Thanks for the opportunity to share our work on the development of novel new markers to describe critical care mild glycemia, something we feel which will actually reshape blood glucose management in this space. Now, mild glycemia in the acute setting is driven by short-term changes in blood glucose secondary to the acute illness. There are 3 distinct forms, and each of these, they don't care if you've got diabetes or not, and they're each associated with patient harm and poor outcomes. 7 major RCTs over a couple of decades have left us more confused than informed, and most of these have resulted in poor patient outcomes in the interventional arm or negative outcomes. Clearly, we need to start thinking differently about this. So if we can establish a precise understanding of acute care mild glycemia beyond our sole reliance on blood glucose, then we're in a position to establish significant clinical gains. With this in mind, we developed a new marker, the glycemic ratio. And this assesses the relative change in glucose from pre-admission levels across the entire admission. And mild glycemia can occur at any point across the admission, so of course it makes sense to have a marker that measures across the entire admission. We know from our previous work that, that running a patient more than 30% below their pre-admission glycemia is at a mortality cost, as is running it too high. So there's a Goldilocks zone just around here. You can also see that a mean blood glucose of 10 at admission can mean different things, very different things for 2 different patients through the eyes of glycemic ratio. For a patient with diabetes, that's no different from his pre-admission glycemia, so that glycemic ratio is 1.0, but for a non-diabetic patient, that's a big rise, that's a 60% rise. So our aim was simple, and it was to define mild glycemia in the critical care using the glycemic ratio. The cohort was from Jamie Crinsley's ICU in New York, data collected over 5 years. The distinguishing feature was 3-hourly blood glucose levels. So this gave us this delightful extra level of granularity that allowed us to assess the duration of exposure above and below nominal thresholds. So first up was stress-induced hyperglycemia, that we specifically looked for a threshold effect here. And you can see as patients were exposed to higher and higher peak glycemic ratios that there was no further mortality penalty and a clear threshold at 1.1. And this is quite consistent with a number of independent observational studies across a wide patient spectrum. So we examined initially the association between the duration of exposure above GR 1.1 And you can see that strong relationship there. Our conventional marker, to the duration above 10, didn't do so well. And you can see here that there's a large number of patients have long durations of exposure there, and it's mainly the domain of people with lower HbA1c. Over here, there's few people with longer duration of exposure and elevating HbA1c. Now, we wanted to try and get a cleaner look at it, so we removed all of the patients with any exposure to absolute or relative hypoglycemia, so we could actually get a bit of a head-to-head comparison, put them in the ring together. And if you see down here, even with under-adjusted mortality, when you put them together, it was a very, very lopsided contest. So our conventional marker of blood glucose above 10 was hopeless, basically. We also considered patients who never experienced a glucose outside the 4 to 10 range. So this is the safe zone. You can be in hospital and with a blood glucose there and you're safe. Everyone knows that. So the graph highlights a striking mortality difference within that safe zone. So these are patients who never experienced a glucose outside of 4 to 10 during the ICU admission. But within that safe zone, you can see here that you can have a pretty looking blood glucose, but underlying that might be an ugly glycemic ratio, and you will pay a mortality benefit for that. Mortality cost for that. Okay. Absolute hypoglycemia. Now, we looked at the duration of exposure below our conventional threshold of 4. And there's a strong relationship, and on the surface it doesn't look like it provided anything more than our conventional RCT marker of excursions below 4. But without showing the information, I can tell you that if you use excursions below 4, there are certain circumstances where it can be quite misleading. Now, the fascinating new kid on the block, relative hypoglycemia. Earlier data indicates that we had a mortality penalty from running them too low. Previous work, other work we've done with this same database suggests it was only apparent in those with a HbA1c of 8% or more, and some work from Melbourne have suggested that it's about the hours below glycemic ratio 0.7 that's important, and it wasn't HbA1c dependent. So we looked at the hours below glycemic ratio, 0.7 of course, but we also looked at the excursions below 0.7, and we felt that there was a possibility that the impact was actually related to the initiation of some sort of counter-regulatory response. So we're interested in that. What we found was, well, initially we couldn't work out what does an excursion below GR 0.7 look like. And it was Earl Hirsch put me down the right path. There's some very old data from a colleague of his in the US. They used insulin to induce hypos in medical students. I'm not sure I'd try and slide that one past ethics just now, but the data was there, and they showed it 12 hours after an initial hypo, a subsequent hypo response was blunted. So we decided, well, okay, we'll look at a 12-hour gap, a 24-hour gap, and a 36-hour gap between excursions. And you can see here the blue bars that still seem to be a blunting response. This is against mortality. A blunted response using 12, but it seemed to max out at a 24-hour gap with no further gain at 36. Over here you can see the number of hours below GR 0.7, and there's really not much to see there. So we gave it a more thorough workout. We put it in a multivariable regression adjusted for absolute hypos, stress hypoglycemia, and for risk, Apache 4 predicted mortality. And you can just see how powerful it is and how significant and how strong the impact was. And again, that the hours below GR 0.7 didn't have an impact. So what did it look like in those with A1C less than 8? There's just nothing. It didn't happen there, so not even a sniff. We also tested it, some sensitivity testing. We lowered the threshold to 7.5, and as soon as we did that, again, the effect was gone. It disappeared. So now we've got 3 markers which we think are independent markers of malglycemia within the ICU. So if we put them all together and adjust them for risk, they should all stand up independently. And this is what we got. And I still get all nerdy scientists excited when I see this, because I just think of the potential for clinical change here. And the way to interpret this is 1 hour of above glycemic ratio 1.1, you would get a 0.2% relative increase on your background mortality. Not an absolute increase, a relative increase. And for 1 hour of hypoglycemia exposure, it'll be a 6.2% increase. So immediately you can see how much more powerful the mortality penalty is for absolute hypoglycemia. It's even stronger for excursions below 0.7, but bear in mind that's only for our patients with HbA1c above 8%, which for our cohort was just 7.8% of the patients. So one of the things this means, the key message is that the harm associated with malglycemia is the sum of these parts. We clinically aspire to achieving a mean glucose or a glycemic ratio within a designated range, but it may not tell us the whole story. With respect to interpreting study results, looking at a mean value just may not tell us the full picture. We might achieve a particular target, but it only tells us the destination. It doesn't tell us the route that it took to get there. This is single-centre data, so of course we need independent verification, of course. We've already obtained data from 2 other RCTs, the glucocabbage and the controlling studies. And on initial analysis, the malglycemia markers have just stood up independently, perfectly, even after adjusting for the study group randomisation within those studies. Further to this, when you look at Vandenberg's initial landmark studies, the Leuven studies, and also the more recent Lucid study, and you apply this process of thinking to those studies, then the results of those studies are explained. We've got further work not presented here which overlays the distinct temporal relationships of the malglycemia. When you apply that, it becomes even clearer again. So in summary, we've redefined our understanding of malglycemia in a critical care setting by using creative thinking to address this issue. We've solved a very significant 25-year mystery, which has been confounding results and impeding our progress in the area. So the possibility of an interventional study around hospital blood glucose management, promising rich clinical rewards, has now become enticingly closer. Thank you.
Thank you, Greg. And do we have any questions from the audience? I'm pleading temporary naivety. I was blown away by the excursions and the odds ratios. Oh, excellent. Catherine.
You have to forgive me. I'm a neonatal intensivist. I know very little about adult intensive care. How do you work out whether this isn't just a biomarker of illness severity as opposed to being causative to the mortality? It's something that we grapple with in other neonatal populations as well, in terms of regulating glycemic control, or just recognising that this is a sick adult, sick baby, and that's why the sugars are off.
So this is the traditional chicken and the egg question. So a patient comes in and they've got stress hyperglycemia, particularly because they've got an acute illness. Now, that's part of coming in with it. If you leave that and don't bring it back, then they're exposed. So the way I think about it is if you look at patients who have an acute increase in their background glucose, then even with about a 30%, 40% increase, your neutrophils become dysfunctional, your platelets get stickier. So maybe something's not going to happen straight away, but if you're sitting there with partial sort of immune suppression, I guess, for 3 days, 5 days, 7 days, then you're a sitting duck for an infection, or you're looking at getting a thrombus-driven event. And that's typically what we see with the stress hyperglycemia, is increased infection. Infections are the real big one, but also an increase in thrombus-driven events, so ischemic stroke and post-MI worse outcomes and so on.
Sorry, follow up to that. perfect answer. So then if you're suggesting that you have interventional studies, you're going to have to be doing individualised medicine, I suppose, measuring the HbA1c on arrival and then calculating what their target GR will be? Is that...
Exactly.
Right.
So really what all this is telling everyone is that we need to do a HbA1c, what's their normal before they came in, and then we need to have a blood glucose target based on that. And you saw with that initial slide that Goldilocks zone is 0.8 to 1. So glycemic ratio 0.8, the way to think about that is 0.8 is probably around your fasting glucose. So 0.8 to 1 probably signifies fasting glucose to about 30% above your normal fasting. So it's the acute change, it's the acute differences. And the hypoglycemia stuff was in there, and certainly the relative hypo stuff we induce in ICU. I think that can be fixed, and the Lucid study tried to do that. The absolute hypos, I see Vandenberg actually just released in the ADA in the US a few months back. Someone sent me a slide, and their core logic insulin management program literally eliminated hypos in their ICU. So we're at a point technologically where we can actually do this stuff. So it's quite exciting.
Excellent. Thank you very much, Greg, and we look forward to your further research. Our next presenter is Sam Henshin, soon to be Dr. Sam Henshin, who will be presenting on behalf of Dr. Dean and the team. And Sam is a Flinders MD4 student, and he will be presenting on measuring outcomes of facial skin cancer surgery using the FaceQ skin cancer module. Over to you, Sam.
Thank you, George. I'll just get this up. Yeah. Yeah, so thank you everyone for giving us the opportunity to present our research. Measuring outcomes of surgery in sort of any surgical discipline is sort of quite sought after information, but can sometimes be quite hard to capture. So thank you for giving us the opportunity to present what we've found around facial skin cancer surgery. So just to give everyone a bit of a background into what we're talking about. So we're talking about skin cancer. So specifically skin cancer in Australia. And funnily enough, so Australia is #1 globally for age-standardised rates of both melanoma and non-melanoma skin cancers. So the non-melanoma skin cancers classify into those basal cell carcinomas and also the squamous cell carcinomas. And unfortunately, more non-melanoma skin cancers have been diagnosed each year than all other cancers combined, with incidence rates almost doubling over the last 40 years. And males represent a higher proportion of these new cases than females in both the melanoma and the non-melanoma subgroups. So these skin carcinomas are primarily induced through repeated UV exposure, UV radiation damage, inducing a malignant transformation in the cells, with highest rates of these seen in areas with these repeated levels of high UV exposure, particularly on the face, posterior neck, ears and scalp. And treatment-wise, surgery is the primary management for the majority of these skin cancers, ideally getting complete removal with histologically clear margins. However, surgery does induce scarring, which comes with its own risks and can impact both patients' appearance and induce negative impacts to their quality of life. So when we had a look at sort of identifying factors which most negatively impact quality of life, both pre and post-operatively, it's important in maximising patient satisfaction and improving their quality of life overall. So all of these factors on the screen sort of play a key role in one patient's quality of life. However, satisfaction with surgical outcomes and appearance heavily contribute into both the physical and psychosocial impacts of cancers, particularly of the face, head and neck. The way that these individualised quality of life values are addressed during the patient and clinician interactions don't only influence treatment decisions, but also play a significant role in formulating a patient's expectations. So we thought, how can we really capture this? And for us, the answer in this case was the FaceQ, and more specifically, the FaceQ facial skin cancer module, which is a validated patient-reported outcome measure, which is comprised of 5 scales and 2 checklists. broadly grouped into 3 domains. So health-related quality of life, which encompasses sort of a cancer worry scale, which focuses on the patient's cancers, including recurrence rates, metastases, and impact on their life. Appearance-related distress, which focuses on psychological distress induced by facial appearance. Sun protection behaviours, which looks at the use of particular sun protection methods. And then adverse effects, which encompasses a subjective reported, the subjective adverse effects reported by the patients. Then the appearance domain, which encompasses satisfaction with facial appearance, as well as appraisal of scars post-operatively. And lastly, experience of care, which discusses the information given to patients about how their appearance would change post-operatively, their future outcomes, as well as timelines and possible solutions or methodologies to help manage and reduce these. So this is a breakdown of what the scales look like, with each individual scale and checklist having a varying number of items and a Likert scale based off what their response would be. And the recall period that we asked these patients to answer these questions to were majority within the last week. And this is an example of what we sent out to those patients with one of the scales on the right there showing the 9 questions and then the 4 different options for how they felt in the last week about that question. So what did we do? So we recruited 107 participants from November 2021 over an 18-month period across both SALHN sites. And we included adults with confirmed skin cancer lesions of the face, head and neck, and purely receiving surgical management for these lesions. We didn't include any minors or any benign lesions or lesions not located in these areas, as well as any other treatments apart from pure surgical management. And what we did then is we sent out these FACE-Q questionnaires, both preoperatively and then at 1, 3, 6 and 12 months post-operatively to try and capture these patient-reported outcome measures at these different time points. So what did we find? So when we looked at the mean scores for all the scales and checklists over time, we saw statistically significant improvements in the satisfaction with facial appearance at 6 months post-operative, as well as decreased cancer worry, reduced appearance-related distress, and a cumulatively increased amount of sun protection behaviours. What this shows is that these individuals that we captured were more satisfied with how they looked and reported decreased levels of psychosocial distress and cancer worry, and were also more sun smart, essentially. For the post-operative scales, at 6 months post-operatively from the time of surgery, we saw statistically significant improvements in the self-reported appraisal of scars over time and decreasing levels of adverse effects reported by the patients. And we saw an overall high level of satisfaction with the information given both pre- and post-operatively around how their appearance would change. We then further broke this down to individual participant characteristics with a snapshot here at 6 months post-operative. With the satisfaction with facial appearance, appraisal of scars, and the satisfaction with information scales, a higher score indicated a better outcome, whereas for cancer worry and appearance-related distress, a lower score actually indicated a better outcome. And all of these scales all the scores were transformed to a score out of 100. So what we saw when we looked at gender is that at 6 months, there was no statistically significant differences between males and females, and the reported outcomes were actually very similar between these 2 genders that we captured. However, unlike gender, there were significant differences when we looked at age. So in comparison to the older participants, 65 years and above, the younger people, less than 65 years old, reported statistically significant differences across all scales. So these younger individuals were less satisfied with their facial appearance, they appraised their scars less, they were less satisfied with the information given about their appearance, and experienced more cancer worry and significantly more appearance-related distress. Looking at cancer type, in comparison to non-melanoma skin cancers, individuals with melanomas reported sort of minimal differences in satisfaction with facial appearance, appearance-related distress, and the appraisal of their scars. And we did see this non-statistically significant difference between cancer worry, and this sort of highlights the expected increased cancer worry in those patients with melanomas because of the natural history of the disease. When we looked at surgical repair type, there was no significant differences between primary and reconstructive closure that we found. However, there was a tendency for those with primary closure only to have primary closure only, to have higher scores, but this didn't reach statistical significance. When we looked at sun protection behaviours as a cumulative number of behaviours performed, looking at minimising UV exposure, wearing sunscreen and protective clothing, we found that combined repair demonstrated higher levels of these sun protection behaviours. Now, this is most likely due to these individuals having multiple lesions and potentially receiving additional, more in-depth education around the importance of sun protection. And lastly, when we looked at adverse effects as a cumulative number, including such things as pain, paresthesia, swelling, bruising, and impaired facial movements, with the lowest possible score here being 10 and the highest being 40, across the board we saw very low levels of adverse effects, with the highest in the younger groups and those receiving reconstructive repair. So how will this research impact clinical services? So overall, we've shown that these appearance-related and health-related quality of life scales and checklists improve post-operatively, highlighting that appropriate surgical care does improve appearance and reduces psychological distress and cancer worry associated with these patients. So the impact we propose this can have is through implementing the FACE-Q scale and its data into practice, which is in a pilot study within SALHN, with the aim to adjust patient expectations based on their gender, age, cancer type, and proposed surgical repair through providing real patient data relevant to their demographic and be able to show them trends over time post-operatively of how these scales can change. In addition to refining patient choices through presenting outcomes from this FACE-Q data to help tailor also which options are presented and chosen by patients based around what their goals and expectations are of following surgery, with the culmination of these factors to improve the informed consent process overall, empowering patients with patient-reported, demographic-relevant data and targeted support for those individuals who fall into those higher risk subgroups for factors which negatively contribute to quality of life. And finally, with our goal to maximise patients' quality of life through delivering the most targeted patient-centred care for those individuals suffering from facial skin cancers. And I'll leave it at that. Thank you very much.
Thank you, Sam. Just a comment before I think when you said gender, you meant sex.
Sex, yes.
All right. Do we have any questions from the audience?
More of a comment, really. I found it interesting that the sun protection behaviours barely pushed like 20%, even post-operatively. But I did notice, was the sample size slightly smaller than for the other checklists and scales?
I probably should have clarified that a bit more. So the sun protection behaviours was a cumulative number. So the maximum was out of 20 for that. Right. Yeah, so yeah.
So closer to 100% then?
Yeah, so around the 80% for those ones, yeah.
If you don't have any other questions, in the interest of time, we might move to the next speaker. Thank you very much,
thank you very
Sam.
much.
And it's over to
Okay, so we're on to our next speaker. We've got Dr. Charlotte Wade, who is a provisional fellow in anaesthesia, and she's going to speak to us about improving skin-to-skin contact at elective caesarean section, a quality improvement initiative at a tertiary maternity facility in South Australia. Take it away.
All right. So hello, my name's Charlotte, and as very kindly introduced, I'm one of the fellows in anaesthesia. You might be wondering what on earth an anaesthetist is here doing talking about skin to skin. Well, the picture you see on the slide is me, and that's me with my second daughter, Elsie. I was very lucky to receive a beautiful birthing experience with amazing skin-to-skin contact right from delivery. Things were a little different with my first daughter, Maisie. She was premature, she weighed 1.6 kilos and was taken to the special care unit pretty much immediately, and I didn't receive any skin-to-skin care. a lot of my passion from this project stems from seeing the difference that a birthing experience can make to a woman. I suffered greatly, both mentally and physically, during the periods of separation from Maisie. And as I took on the obstetric provisional fellow role earlier this year, I became increasingly frustrated at the lack of skin-to-skin that we were providing in theatre. Now, it's not just me that places importance upon skin-to-skin. This is some feedback that I actually received via email from a patient who I anaesthetised for their caesarean section. She wrote in that email, "But what made my experience even more special was the way that you facilitated the skin-to-skin touch process right after my baby was born. The way you carefully handed my baby over to me, making sure that we had immediate skin-to-skin contact, was a moment that I will always cherish." And I'm very proud to have received that email. So is skin-to-skin really that important? I'm standing here at Research Week surrounded by some amazing researchers full of really strong evidence-based work. Well, skin-to-skin is also highly evidence-based. We know that early skin-to-skin increases the initiation of breastfeeding or natural feeding behaviours. So regardless if you go on to breastfeed or bottle feed, we know that early feeding behaviours are driven by early skin-to-skin. We know that there is a transfer of bacteria from mother to baby, so friendly colonisation of good bacteria. We know that stabilisation of temperature, heart rate, breathing rate also occurs once the baby is on the chest, reducing neonatal anxiety, maternal anxiety, and in turn reducing rates potentially of postpartum depression and anxiety. We also know that there's a surge of hormones released once the baby is put on the chest, oxytocin release, reducing the risk of postpartum hemorrhage. There are guidelines surrounding skin-to-skin. The WHO and UNICEF have a worldwide project called the Baby Friendly Hospital Initiative. This project drives to improve maternity outcomes with a particular focus on breastfeeding. However, in Australia, we have the Baby Friendly Health Initiative, which is a derivative of that group run by the Royal College of Midwives here. The Baby Friendly Health Initiative takes the focus off breastfeeding and rather places it onto providing a gold standard maternity care regardless of your choice to breast or bottle feed. Now, Flinders is a baby accredited hospital facility, so we should be abiding by the rules of the book. With regards to skin-to-skin, the optimum standard is to place a baby on the chest within 5 minutes of birth or immediately if possible. And that's the optimum standard. The minimum standard to be a baby-friendly hospital is to place the baby on the chest in recovery. But in my mind, at a caesarean section, an hour has passed, and that is an hour of benefit that you have wasted. The BSLs for our hypoglycemic babies who are born to diabetic mothers are taken at 1 hour. Well, if we could initiate feeding earlier, a drop of colostrum might be enough to prevent hypoglycemia in that baby. And by the time the baby gets into recovery at 1 hour, that's the time the BGL is going to be taken. You've missed an opportunity. So I channeled my inner spy. I hopefully was a little more James Bond than Austin Powers, and I performed a secret audit. I was conscious that if anybody found out about my audit of current practice and babies were started to be put on the chest, then I would introduce the Hawthorne effect. It seemed like mission impossible. However, we did it. We audited 46 caesarean sections in secret. We found out that only 6 cases received skin-to-skin within 5 minutes. And in fact, probably far more worryingly, only half of babies received skin-to-skin at all in theatre. So we formed a quality improvement team. Anaesthetics, obstetrics, neonates, and midwifery all came together, and we decided that within 6 months, we wanted 90% of our babies that were delivered by elective caesarean section to be placed skin-to-skin with their mother within 5 minutes of birth unless their condition prevented it. We thought that if skin to skin was unable to be provided, it should be clearly documented in the notes. So we used process mapping, fishbone diagrams and Pareto charting to systematically examine the patient journey for elective caesarean section. And you can see that it is extremely complicated from those the journey maps that people take to caesarean section, and there is absolutely no standardisation of care. The issues that we identified include a lack of education and awareness of the importance of skin to skin at caesarean section, so nobody felt strongly about doing it. We discovered that there were workflow issues for neonates and midwifery, and things that highlighted that were the baby checks. So at some point after the baby is born, there needs to be a newborn baby check, and that's usually performed by the neonatal doctors. If they're not able to perform it because the baby is on the chest, who is? And so we needed to really knot out some workflow issues. We know that babies need to be safe if they're on the chest, and we realised that our neonatal registrars don't receive any training in normal caesarean section care. Of course they are trained to resuscitate babies, that's the whole purpose of them being there. And so then, of course, they are then ready to intervene as soon as the baby is placed on the chest. However, training, we believe, should be provided in observing a baby undertake that natural transition process on the mother's chest. There was lots of concerns raised about neonatal hypothermia, and so we measured the temperatures in theatre. They're very cold, and so it is a very understandable concern that people have. The temperature in theatre is averaging 18 degrees, whereas those on BAS are 21, and in the neonatal unit are 25, 26 degrees. Patient information and consent. Nobody is allocated to talk to women about this. And in fact, did you know there is no antenatal information provided to women in this hospital regarding skin-to-skin care? A complete anomaly to all the other hospitals around Australia, pretty much. We also have a lack of locally agreed guidelines, and so there is no standardisation of care or recommendations for skin-to-skin at SALHN. So where are we up to? We're currently in the implementation phase of our project. We have created consumer information which has been passed through and now freely available on the intranet. We are in the process of creating a protocol for theatres. All specialties have now provided feedback that's been accumulated, and we'll go through the relevant panels very shortly. So the future, what I hope to see is we're hoping to secure funding. We would like to employ a research midwife to join us on our journey to strive for this excellent care for our women. We want to implement long-lasting culture change. We want to monitor for outcomes that may occur as a result of this project. We of course want to see our babies on the chest, but we need to make sure that babies are not cold. We want to monitor neonatal admissions related to hypothermia, to hypoglycemia and to tachypnea. Hopefully we will see a reduction in these rather than an increase. We also need to invest time and effort into warming devices for our women, such as underbody warmers, so that we can really start to make proper changes to address the concerns that we found during our project. Thank you for your time.
Thank you, Charlotte. Any questions from the audience to get us started? Oh, here we go.
I just wanted to say I'm a research midwife, started last 3 weeks ago, and I totally agree with you, and I'm happy to join.
Thank you.
Yeah.
I have some questions. I'm a neonatologist. I'm very interested in this. I'm not involved in the project at all, guys, just so you know. So my immediate thoughts are all about preventing hypothermia, subsequent hypoglycemia, delayed transition. That's probably the priority for me. So what strategies are you going to do in the theatres, changing practice from an anaesthetic or obstetric point of view to achieve that? So I'm thinking you need more surface area to get the baby on, you might need to move the drape down, you might need to heat up the theatres. Are there other specialties open to those changes?
Yeah. So the whole project, it was a bit awkward, as an anaesthetist. I spoke to Scott Morris from neonatology, and it's really hard to go to another specialty and start to say, oh, I'd really like you to put babies on the chest, and he was actually incredibly receptive. So, and when I spoke to midwives and to obstetricians, actually I think it's something that everybody wanted secretly, and nobody had just started the chain of getting it going. So yes, everybody's on board, and our group has people from all the specialties involved. So in terms of mitigating those concerns, theatres are going to be warmed to 21 degrees for all caesarean sections. If we secure some funding, we will get underbody warmers, and I do have some other groups that are interested in underbody warmers, such as the green theatres, because we're then not wasting overbody warmers. We can't use them in skin to skin because that's where they go, but all other patients receive a disposable overbody warmer when they're having an operation, so green theatres are on board, and so are the paediatric anaesthetists, because having an underbody warmer is pretty handy for the little ones too. So there's a move to using an underbody warmer. In terms of the hypoglycemia, that's something that we're hoping to prevent by early initiation of feeding, rather than having that first feed taking place in recovery an hour post-delivery. A lot of the sections that I do where I push for skin-to-skin babies feed in theatre, and you only need that little drop of colostrum to help with those hypoglycemic babies. So hopefully the protocol, improving access, part of the standardised setup that we're putting in the protocol is both arms out the gown. Cannula should be in the hand rather than the ACF, so that the mum can reach up, and it should be put in the non-dominant hand so she can hold her baby and pat her baby. So we've tried to standardise everything, ECG dots on the back, so that they're not on the mother's chest in the way of skin to skin.
Wonderful, thank you. Thanks, everybody. Okay, that brings us to our next presentation. We've got Catherine Tyver, who's talking to us about sodium glucose co-transporter 2 inhibitor use in type 2 diabetes is associated with a lower rate of atrial arrhythmias in a real-world population.
Thank you for this opportunity to present today. So what is atrial fibrillation? It is an irregular heart rhythm, and as the name suggests, it comes from the cardiac atria, the upper chambers of the heart. And what happens is that instead of the atria being activated in an organised, regular fashion, say 60 to 100 beats a minute, and your heart goes at 60 to 100 beats a minute, the atria do this thing where they fibrillate in a constant disorganised fashion, like you can see in this video. So atrial fibrillation, or we call it AF, is a significant health problem. And the reason for that is because it's, number one, it's common, and it's got an increasing prevalence due to increasing metabolic risk factors for AF, and also technologies that are detecting earlier and earlier AF. And it brings with it problems, and the first of those is symptoms. So it causes palpitations, shortness of breath, and fatigue. And it's also associated with some adverse health outcomes like heart failure, stroke, hospitalisation, and mortality. And one of the problems that we face is that AF treatment options include antiarrhythmic tablets and AF ablation, and each of these have major limitations, including side effects, risks, and lack of long-term efficacy. So this brings us to this class of medications called sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. And this forms a drug class which was initially developed for the treatment of type 2 diabetes. And it's in widespread use for this clinical indication. And the main textbook mechanism of action for diabetes is for this tablet to block glucose reuptake in the kidney, resulting in lower levels of glucose in the bloodstream. And in fact, these medications have now been extensively studied and subsequently adopted for use in heart failure and also chronic kidney disease. And as a result of the clinical trial data in these populations, we now have post-hoc analyses and meta-analyses of clinical trials reporting that SGLT2 inhibitors are also associated with lower rates of atrial and ventricular arrhythmias. This forest plot shows the most comprehensive meta-analysis to date, involving just over 75,000 patients and 31 clinical trials. And the authors examined SGLT2 inhibitors versus placebo on the outcome of incident atrial arrhythmias and found a statistically significant risk ratio of 0.75 favouring SGLT2 inhibitors. Now, there are large-scale randomised trials evaluating this question specifically, but really the real-world effect outside of the sometimes very highly selected clinical trial population is less commonly reported. So the objective of our analysis was to determine the effects of SGLT2 inhibitors on cardiac arrhythmias in a real-world population. We undertook a retrospective cohort study using a database of inpatient hospital encounters in South Australia in which SGLT2 inhibitors were prescribed. The time period evaluated was 2011 until 2019, and importantly, this is an era in which the use of these medications was predominantly for its indication in diabetes before the widespread use in Australia for heart failure or kidney disease. We included those with type 2 diabetes, with or without a previous cardiac history, and those who were prescribed an additional glucose-lowering medication. We excluded those with an estimated GFR of less than 30 mils per minute and those more than 80 years, and those who were previously prescribed SGLT2 inhibitors to capture the new prescriptions. This left us with 882 patients with diabetes who received these medications, which we temporally matched with 3,282 controls. We adjusted the baseline characteristics using inverse probability treatment weighting, using gender, age, 12 comorbidities and 8 medications to perform the adjustment. And we confirmed quality of the matching using standardised difference of the means. The incidence of outcomes was used from hospital admission coding data, and we performed a Cox regression analysis. The primary focus was to evaluate the incidence of atrial arrhythmias, so we included atrial fibrillation and flutter under the banner of various classifications and all of these ICD-10 codes. We also looked at ventricular arrhythmias, which included ventricular tachycardia and fibrillation, and also looked at cardiac arrest, and then a composite outcome of a mixed group of tachyarrhythmias, which basically all of the different fast heart rates. In terms of the baseline characteristics prior to our adjustment, we had a population with a median age of 63, about a third female. And interestingly, the group who was prescribed SGLT2 inhibitors were more likely to have AF and much more likely to have vascular issues, including hypertension, myocardial infarction, coronary revascularization, as well as heart failure. And what this means is that doctors were more likely to prescribe these medications in the presence of these comorbidities. Interestingly, renal function was slightly better in the group who received SGLT2 inhibitors, and this really reflects the fact that this was done at a time before we had good data for these medications in kidney disease, and reflects clinician hesitancy to prescribe these medications in impaired GFR patients. This table really just shows the fact that after our propensity matching, there were very, very low standardised differences of the means, indicating that the groups were very well matched. What we found was that SGLT2 inhibitors were associated with a significantly lower rate of atrial arrhythmias at 2 years of follow-up. We repeated the analyses with standard added covariance and did some sensitivity analyses, and the independent relationship remained. When tachyarrhythmias as a group were evaluated, there was also a reduction in atrial arrhythmias, and ventricular arrhythmias and cardiac arrest didn't reach statistical significance. Now, one of the things that is alarming about these results is that we have to remember that it's not randomised data, and even though we match the cohorts on known confounders, without randomisation we can't possibly match for unknown confounders. And as such, if clinicians chose to give SGLT2 inhibitors to a different population of people, possibly they're less likely to have AF just because they're a different population, not because of the treatment. But quite strikingly, what we found is that all-cause mortality, the best marker of general sickness in a population, was actually twofold higher in those who had SGLT2 inhibitors prescribed. And despite that, they had less atrial arrhythmias. Now, we know from large randomised data sets that, in fact, SGLT2 inhibitors don't increase mortality. So the reason for this signal is that of increased mortality here is that the SGLT2 inhibitor group were more sick, and clinicians prescribed these tablets because the patients were more sick. And the finding that fewer atrial arrhythmias occurred in the sicker group actually strengthens our result. This slide shows those with a history of previous atrial fibrillation on the left and those without previous atrial fibrillation on the right. And you can see, unsurprisingly, that the overall absolute incidence of atrial arrhythmias is much higher in those with previous AF on the left. In both groups, the point estimate of the incidence of atrial arrhythmias was lower in the SGLT2 group, and this was statistically significant in the group without a history of prior AF, which included many more patients. Now, as we wanted to assess the real-world effects of SGLT2 inhibitors in our population, we've analysed non-randomised data. But because of the fact that we're able to understand the confounders like I've explained to you, the conclusions are more likely to be valid despite this limitation. We did use an inpatient population, which means that we haven't included many of the outpatients that are being prescribed these medications and therefore enriching for a sicker population. In addition, because we used inpatient encounters, we were very reliant on discharge coding data for our results. But arguably, if you had a clinically relevant episode of AF, it was more likely to be recorded. In terms of the potential mechanisms, many basic sciences papers have reported multiple potential reasons that SGLT2 inhibitors may lead to this reduction in atrial arrhythmias. This includes change to atrial dilation, changes to risk factors like weight and blood pressure, changes to sympathetic nervous system activity, atrial remodeling, changes to myocardial energenetics, inflammation, epicardial fat, and epithelial function. So in conclusion, SGLT2 inhibitor use was associated with a lower incidence of atrial arrhythmias in a real-world patient cohort. This was despite a sicker cohort receiving the medication, as evidenced by a high rate of death. Broad cardiometabolic benefits are plausible in AF, which commonly has cardiometabolic risk factors and complications. Prospective trials are underway to determine the effects of SGLT2 inhibitors as specific AF pharmacotherapy, irrespective of diabetic status. And until that point, I think our current clinical use of SGLT2 inhibitors should reflect existing randomised trial data. Thank you.
Thank you, Catherine. Lovely talk. Do we have some questions from the audience?
Is there any suggestion that those drugs, and I'm not a cardiologist, but that they protect against the development of arrhythmias in patients who have had COVID? Because, I mean, COVID is associated with AF and other arrhythmias, so...
Yeah, so thanks. Look, I am not aware of any specific data in the post-COVID population. However, I think there are a lot of similar pathophysiological sort of entities going on in terms of the inflammatory process, and there are some basic sciences papers that show that there's reduction in inflammatory mediators. We know that things like atrial fibrosis and dilation and things like blood pressure surges have been linked to development of atrial fibrillation and have also been shown to be altered by giving these medications in basic sciences papers. So it's a great hypothesis, I think, yeah.
Any other questions from the audience? I can ask probably not a quick question really, about the reliability of the ICD-10 coding as an outcome measure. It's something that I'm working with at the moment in some work that we're doing, so I'm interested to hear your perspective on that. Yeah, so look, in terms of, obviously, that's why I mentioned it up front as a limitation, because it's not going to capture absolutely every AF episode that happens. I think there's sort of a spectrum of AF episodes that happens is, 10 seconds of AF that happens, that may or may not even be recorded. That won't get reflected on ICD-10 coding data, but that's probably not clinically relevant either. So I think if it's clinically relevant enough to cause symptoms or to cause a doctor to write it in the notes, then it probably will end up on the ICD-10 list. And then I think, we've captured the same data in both groups. So I think that, obviously it does have its limitations, but I don't think it discounts the validity of what we found. Yeah. Thank you. Thanks, Catherine. All right, that brings us to our last speaker for today, Ms. Sarah Madigan, who is a respiratory scientist. speaking about changes in physiological parameters measured by cardiopulmonary exercise testing in patients with systemic sclerosis.
Thank you. It's always nice to be last. So systemic sclerosis or scleroderma is a multi-organ disease which is characterised by inflammation, vasculopathy and interstitial fibrosis. 5 to 12% of patients will go on to develop pulmonary arterial hypertension or PAH, which is a debilitating disease with poor patient outcomes, and it's one of the main causes of mortality in this population, and it causes 30% of all reported deaths. Because of this, patients get screened every year to try and before a referral to a possible right heart catheter. So current screening methods that we use are like the Australian Scleroderma Interest Group, which we can see here on the right. This is a very simple algorithm, and it includes PFTs and NT-proBNP. And although it has a really high sensitivity, the specificity is quite poor. So the reason we're investigating the use of a cardiopulmonary exercise test, or a CPET, is that it may help identify patients with scleroderma who screen positive on one of these algorithms, but is actually thought to be at low risk of having PAH. The literature shows that when we incorporate the CPET into the DETECT screening algorithm, it did increase the specificity in scleroderma patients, but the DETECT algorithm is really dependent on echo results, which can sometimes be difficult to get in these patients. Literature also demonstrates that CPETs show early changes of pulmonary vasculopathy, or PV, in scleroderma patients, who then went on to have a normal right heart catheter. And PV is thought to predate the development of PAH. So my PhD aims to assess the use of the CPET in screening for PAH in a clinical scleroderma patient with the aim to reduce the number of right heart catheter these patients have to undertake. And the research questions I'll be covering today is, can CPETs in scleroderma patients predict the development of PAH? And do serial CPETs detect changes earlier than other methods? Now, for the detection of PAH, the key parameters that we look for on the standard 9-panel plot are the VE/VCO2 slope, the oxygen pulse, peak oxygen uptake, end tidal CO2, and where anaerobic threshold occurs, with the other plots not being used specifically for this detection. And these important parameters will be explored later in more detail. So for statistical analysis, all patients enrolled with the study with at least one CPET results have been included in the analysis I present. We adjusted all our results based on gender, age at first CPET, and their use of cardiac medication. Mean values were established for CPET 1 and CPET 2, and then we looked at the differences between CPETs using a linear mixed effect model, which allowed us to use all of our results. So patients diagnosed with scleroderma were invited to participate in this study at their annual screening for PAH at their rheumatology appointment. And then we tried to get patients as close to possible to recruitment to come and complete a maximal CPET, and then complete their next CPET at their next annual screening. Patients' results were assessed on an individual basis for the presence of pulmonary vasculopathy, and then physiological parameters between CPET 1 and CPET 2 were assessed for any changes. So there have been 63 patients that have completed the CPET 1 and 32 have gone on to complete CPET 2. The average time between CPETs was 11.8 months and the average age was 57.3 years. And in keeping with the disease population, we have more females than males. We have 79% of the population diagnosed with limited scleroderma, which is a representation of a clinical scleroderma population, with a BMI of 27 and 41% were on cardiac medication at first CPET. So like I said, all CPETs were individually assessed for a cause of limitation. And we found that 43% of patients at CPET 1 were limited by their cardiac response and 31 were considered normal. And then, 38 were considered normal at the first CPET. This trend continued in CPET 2, where 50% were limited by cardiac and a further 31% were considered normal. Between CPETs, 13 or 41% of patients actually had a decline in their results, 2 or 6% had an improvement, and only one patient saw a change in their CPET limitation, which went from being normal at their first CPET to being cardiac limited at their second. So now we'll look at those parameters in more detail. And these are actually my patient results who are participating in the study. So this is a plot of minute ventilation over carbon dioxide production. And as you can see in the, let's see if it's, no, on the, oh, that went forward. As you can see on the one on the right, these parameters are closely linked by that narrow predicted area. When we look at the one closer to me, this patient's steep slope shows that they've had to increase their ventilation greatly to eliminate the carbon dioxide. And this shows that there is inefficient gas exchange, and the steeper the slope, the more the impairment. So when we look at our results between CPETs, we can see there was no significant change in the slope. Now looking at oxygen pulse, which is the blue dots, this is a product of stroke volume and oxygen extraction, and it non-invasively reflects the amount of oxygen consumed per heartbeat in response to exercise. So oxygen pulse should rise steadily throughout exercise, and we can see with the patient closest to me that this is very low and flat, well below the reference values, and this is suggestive of a cardiac impairment. When we look at our results between CPETs, we can see there's no significant change in the results, although there is a trend towards lower values being achieved at CPET2. Now, oxygen pulse, which are these blue dots, should increase in sync with work, which is the green dots. In normal people, this increase in oxygen uptake is 10 mils per minute per watt. And peak oxygen uptake describes the patient's maximal exercise capacity. And we can see that in the second plot that the oxygen uptake is low, well below the reference values, and it appears to be flattening. These results can be presented in two ways, as mils per minute or mils per minute per kilo. And when we look at our results between CPETs, we can see that there's been a significant decline in results when we look at the mils per minute. And although there is a trend towards that when we look at mils per minute per kilo, it doesn't reach significance. Now, end-tidal CO2, which are these red dots, is plotted over time. And in a normal patient, this should increase from rest by 3 to 8 milligrams of mercury, reaching the ventilatory threshold before decreasing as maximal effort is approached due to increased ventilation. We can see in this second plot that end-tidal CO2 is declining from loaded cycling, and this is consistent with gas exchange impairment. And when we look at our results between CPETs, we can see there was no significant change. Now, anaerobic threshold is normally between 40 to 60% of predicted maximum oxygen uptake, and anaerobic thresholds are often low where there is impaired oxygen delivery. We're looking at our results between CPETs, we can see that there is a trend for an earlier anaerobic threshold in CPET2, but it didn't reach significance. Now, not related to the development of PAH, but looking at the group as a whole, we noticed that there was a decline in the maximum load achieved between CPET1 and CPET2 that was significant. So then we looked at the respiratory exchange ratio, which is the carbon dioxide output and the oxygen uptake divided by, and it allows for the determination of anaerobic threshold, but it's also a marker of patient effort, with a value of above 1.1 being considered good effort. So we can see that there's actually been a significant increase in RER, so this reflects that there had been no decline in effort between CPETs in our patients. So in conclusion, 51% of patients so far have completed 2 CPETs in the study. 1 patient had a change in the limitation of CPET from normal to cardiac disease. No patient in the study so far has been diagnosed with PAH from a right heart catheter. And there has been a decline in maximum load and peak oxygen uptake achieved, which is suggestive of a decline in physical fitness. And due to the increasing RER, we don't think that it's due to a decline in effort. And there's been no significant decline in other parameters of interest for the PAH detection. I'd like to acknowledge mainly my patients who turn up.
Thanks, Sarah. Any questions? Oh.
Hi, I was just going to ask, obviously the number of participants in the second
test was only half the participants in the first test. And I presume that's because the study's ongoing?
Yes.
Yeah. And I just wanted to ask, are the characteristics of the patients as a whole similar, like age matching and that kind of thing?
So the only difference we found between the baseline and those that have completed CPET-2 is there is a slight change in BMI, which is why we think that we didn't get the meals per minute per kilo. It is ongoing, so I finished my data collection in February next year. I have lost some to the study due to a change in health status or moving, but the patients will also go on and complete a third CPET, so we've got lots of data coming through.
That decline that you saw between the two studies, is that expected for age, or is that more than you would expect? Do you think it's your patient population?
It's difficult to answer because mainly people do one CPET and then we never see them again. We're one of the few studies that are actually making the people get back on the bike. A decline in load could be a reflection of a number of things. These patients come with lots of other comorbidities as well that change over time. So we're not sure if that decline in load is just because we've done it within 12 months. So we're really keen to see what happens when we look at the third CPET. Do we continue to see that decline in physical fitness, or have we just got like a little blip in the change over time?
Wonderful. If there's no more questions, a round of applause. Thank you. So that brings our session to a close. And if you could join me in thanking all of our speakers. I think we've had a wonderful lot of presentations. And thanks, George, for helping me chair. Just a reminder, if you haven't already, to get onto Slido and vote for the best presentation for this afternoon. There is a cash prize for the presenter, so it is really worth doing to support them and their research. But if there's nothing else to say, then that brings the day to a close. Thanks for coming.